Good morning, everyone, again. So my name is Dr. Anisha Jean. I am one of the faculty here at Caldwell University. I teach NU 420, Community and Public Health, and I will be inviting Sister Joanne Burney to come up and give us an opening prayer for invocation.
I have to be careful what I say. It's nice to be here for a round grounds, okay? When I was a freshman, I experienced my first rounds, and you know how I experienced it? I was making a bed in a ward, and they put the curtain between my bed that I was making and the next bed so that the doctors and the medical students could have rounds. And I looked through the curtain, not one nurse there. I said, something has to happen to change. And here we have our own rounds. Okay, we are going to ask. It didn't happen because of me, but I prayed. Okay, let us pray this morning. Dear God, we ask your blessings upon these nurses that are going to change the world. Maybe they're not to change the world in the encompassing numbers, but in the one person, one by one, that they will touch. We ask your blessings on all the work that they have done, those professors who have overseen their work, and we ask you to continue learning and growing. Amen.
I almost forgot I was here on a professional capacity. All right, so good morning, everyone, and welcome to Caldwell University's School of Nursing and Public Health's first Innovative Intercurriculum Conference on Health Promotion and Health Maintenance. This event sort of came about in a very organic way, and I'm very excited to give this an opportunity to become something that we do as a department, as a school, on an annual basis, because I feel like it's really important for students to experience educational conferences and experience the opportunity to present their work and their passion, because they've lived with these topics and lived with this work over the course of a arduous semester, right? It's long work, and you get to kind of really display all of the your efforts. So again, this event is sponsored by Sigma Psi Nu chapter here at Caldwell. So we are really grateful to have refreshments throughout the day to keep us recharged. Today, the students will be presenting Today, the students will have the opportunity to present after having completed their third and fifth semester in the nursing curriculum, right? So we're going to see two levels of students presenting. Hopefully, the students completing their third semester in the nursing curriculum get to kind of see what is ahead. And I also want to extend the opportunity for the faculty, because many of you will be meeting these faculty members when you are in NU 420, to almost start to have the conversation and prime yourselves and prime the experience that you will be having when you are a senior and graduating. So the curriculum, the students will have an opportunity to explore or give us a comprehensive exploration of the prevention strategies across the entire health continuum. We know that the healthcare landscape is evolving and moving toward a preventative and chronic disease management. So this is an invaluable opportunity for the students to deliver holistic, client-centered care for communities and individuals. So again, the purpose of this event today is to allow participants to exemplify their competence in the successful completion of NU 306, Adult Health 1, and NU 420, Public Health, Community and Public Health Nursing clinical portions of the course. Students will show their knowledge in the principles and applications of all levels of prevention and the implementation of health programs such as education campaigns, screening programs, and advocacy efforts addressing social determinants, which is really exciting. Students will apply evidence-based practice and clinical decision-making in their care of the clients in their communities. The clinical competencies we will see exhibited today include interpersonal and intrapersonal communication, collaboration, professionalism, and evidence-based practice. Overall, the students will be challenged to reimagine nursing's crucial role in transforming healthcare by promoting health, managing disease, and unlocking human capability for communities and individuals across the lifespan. So very similar to our prayer this morning, you will be change agents and you will change the landscape of our healthcare system. So upon completion of the day, I would like everyone to participate in a evaluation. The QR code for the evaluation can be found probably on the back of some of your programs, but if it's not on the back of your programs, because some of them were printed up a little earlier, you will be able to scan the QR code that's posted throughout the auditorium. Please try and do that before you leave today. We'll also post them on our Blackboard pages so that you have access to that and an opportunity to provide some feedback for your peers and for the day. So I just want to thank you for your attention, and I want to give Professor Pennington an opportunity to make comments. Thanks, guys. Enjoy the day, too.
Wow. Good morning, everyone. So I thought I was like coming up here to be Vanna White and just like introduce the first group, but I'm going to say that I am, so excited to see your projects because I was with the seniors in the spring last year when they did their grand rounds. So juniors, they know where you're coming from in terms of doing your grand rounds presentations. And then to see the growth in your educational capabilities from last spring to this spring in what you're bringing to the table in terms of serving a community. So my junior students worked closely with their clinical faculty to create the project that they're going to present for you today on their patients. And they do have some really interesting topics, I can say. They picked some pretty complex patients. So we'll see how they kind of lay them out there. I'm excited. So I am going to bring up the first group that's nicely waiting in the wings to make me stop publicly speaking. And if you guys want to come up, like now, yay, okay. I'm going to try to mitigate the technical difficulty I'm having right now, and we'll see what we can do.
We have our slides printed out, so it's not the end of the world.
But the presentation has to go up.
Oh, true.
You have your slide? All right.
Yep, right here, everyone. I'm gonna read off my. Whoa. Oh God.
All right, so in
Whoopsie.
order to transition, because I can't see here, and we'll fix that, just use the clicker to transition.
Oh, I got that.
Oh, okay.
I got the bag.
Oh, we
Thank
can't
you.
see the thing?
Not right now,
Oh, we have
because I can't make it come up.
I got it. There's a piece of paper that was in order.
I can't make it come up.
Oh, so that's just been sitting here this whole time?
What?
No, there's stuff on it.
Wait, can I see if this works like to move? Oh, there we go.
Oh, there we go.
Oh, we got it. Sorry, Nadine. What did I do? Oh, not you. I think it's me.
Can we like bend
Who's not as possible? Yeah, of course, me. So we're on YouTube, guys. What?
Seriously?
Is that better?
So
I didn't give it. It's your turn to present. Like walk up to the mic, so you can hear us. Okay. It's not working. Oh, it should be good. Okay. Should we say hi?
Yeah, or should we, and I'll say hi, our project, and then should I say I'm Chloe and then go around?
Yeah.
Okay.
Okay, let's go.
You know the order of the slides?
Go for it.
All right, are we ready?
Yeah.
Wait, what do I press to move
They
this to
use the-
space?
I have it.
Oh, okay, perfect.
Sorry for the technical difficulties. We are the first group, so
Wait, is it not
please
up anymore?
bear with us.
Well, I can't see anything, so I don't know. No, I know that. Okay,
But is it changing on the computer or no?
no.
Separate.
There we go.
All right.
Oh, jeez, I can't even see.
Hi, everyone. I'm Chloe. Our project was Wayne for All Ages, Health Promotion Intervention, and Community Survey for Older Adults in Wayne Township.
No? Okay. All right, so Wayne for All Ages is an age-friendly initiative that was developed in collaboration with multiple community leaders and stakeholders to identify and address the needs and concerns of the older adult residents living in Wayne Township. Our group worked together with Rosemary A. Campora, the Wayne Township Department's Senior and Social Services Director and leader of the Wayne for All Ages initiative, to create a survey for adults 45 years and older, along with putting together a journaling event for this group to better their socialization, reduce stress, improve memory recall, and improve fine motor skills.
We good? So for the survey, the target population were adults 45 years and older. They had to be current residents of Wayne Township, and it was in collaboration with the Wayne for All Ages, so Rosemary A. Campora.
It's like switching the slides without. Yeah, I don't know.
Okay. What's problem statement?
The computer's frozen, guys. We're just gonna take a second. It's still not switching over.
It is what it is. Oh, geez.
Like even when you don't touch it, it switches.
Is it on problem statement? Yeah.
Amanda, do you want to pass me that laptop?
All right.
Thank you.
Our problem statement reads, increased risk of isolation among the older adult population related to lack of community involvement in age-related social changes as evidenced by approximately 1/4 of Americans aged 65 and older who are considered socially isolated and report feeling lonely.
Our objective for this project is to increase access to socialization for adults in Wayne Township who are 45 years and older. The main goals that we focused on is to create a community survey for our target population. By doing that, Wayne for All Ages will be able to obtain information that allows improvement for socialization by increasing outreach and creating health promotion programs. Our second goal is to create a health promotion program for our target population that would increase their socialization, reduce their stress, improve their memory, and improve the lives of older adults in Wayne Township communities.
So these are two of the flyers that we used. The one on the left was for the actual survey, and the one on the right was for the journaling event. One thing that we want to keep in mind is that we want it to be visible to older eyes. So we made sure to use colors that they could see and really make it colorful so everything pops out. These were put at the Wayne for All Ages actual, like the building that they used for the event. So we saw our flyers in a little like rotating flyer holder, which was really cool. And it was also mentioned on the Wayne Township website where you can actually like apply to these events. So we were mentioned, it had Caldwell University on it, that it was going to be ran by the students. So that was really cool to see too.
All right, so when we were creating our survey, these are the questions that we included. So the age, the years residing in Wayne, best times and days for events at the Wayne Township Community Center, types and programs, including activities that they would like to see, any accessibility concerns that they have coming into our facility, their knowledge of the existing town resources, and opinions of health and wellness services available. So this is a copy of our survey. If anyone wants to see it, feel free to see us after and we can show you. We did conduct a small sample group to determine how our survey was coming across to a group of older adults. They said that they really enjoyed it. It was professional, easy to read, but they did ask that we make it shorter, that it was a little long. So we condensed that based on their feedback from the sample group.
The survey distribution was paper and digital surveys. We made sealed, secured boxes for completed paper surveys and placed them at the following locations. They were placed at Wayne for All Ages Resource Center, the Wayne Township Library, and the Wayne Township Municipal Building.
So based on the research that we have done, we found that the benefits of journaling included increased socialization, it reduces stress and anxiety, it improves memory, and deepens self-discovery.
The process of journaling. So attendees were provided journals and prompts that help facilitate memory recall and guide them in their journaling process. Explanations of journaling benefits were provided and examples of possible responses to the journaling prompts as well. Participants were provided with motivational stickers, washi tape, colorful markers to decorate their journals, and were encouraged to discuss amongst each other.
So during the actual event, we went over all of the different prompts that we had in each journal and what could be beneficial for them, whether it was memory recall or just being in touch with their own feelings and memories and things of that nature. They had also spoken during their journaling about what they were writing about and what they were feeling while they were writing. And I think that's what they benefited a lot from, was the actual conversation during the journaling. And a lot of them related a lot to the prompts and allowed them to explore memories that they hadn't in the past, like 5, 10, 15 years. So there were definitely a lot of benefits to the specific prompts we chose, which are included on the poster board too, if you guys want to see what prompts we specifically did.
This is a copy of the journal prompts we provided for them while walking around when everybody got comfortable and settled in. The journal prompts that we saw used most frequently were: draw 3 things that make you smile, what is on your mind, create a frame, draw a memory and reflect, and what are you grateful for?
So in order to gauge the actual success of the event and if anyone actually did get anything out of it, we spoke to a lot of the participants and asked them how they felt. And a lot of these people were pretty blunt and honest while they were journaling. And so it was definitely really helpful to gauge how they were feeling about it. And we got a lot of positive feedback, both when we were there and afterwards. We spoke to Rosemary A. Campora, who was the director of the center, and even when we weren't present, they were giving really positive feedback. They were saying that it kept their mind off of the things that tend to weigh them down and that they were able to remember their fond memories. And they were definitely confiding in each other too while they were journaling. So even if it wasn't necessarily related to the prompt, they were starting to relate it to other things in their life. One member had revealed that she had just been diagnosed with Alzheimer's, and another shared that she just suffered from the loss of her father. So it was definitely interesting to see where the journal prompts led to conversation. So people were crying and laughing with each other, and overall they just said it felt really good to socialize and take that time to just like reflect. So it seems like it went really great on their end. That's it. So we definitely overall feel that journaling was really, really successful in improving the memory recall, and the emotional benefits were definitely expressed by the participants. So it's definitely something that we would implement on geriatric units or just in the general population. So definitely an interesting way to interact with the population.
Does anyone in the audience have questions for them that they would like to ask about their project? We're silent because it's early. Ooh, Kelly, okay.
Do you feel you reached everyone in the Wayne Township that you needed to reach by how you set out the survey? Or do you feel that there could have been a better way? I'm just thinking about the people who don't really frequent the library or maybe the senior center. Do you feel like you did enough to get to everybody in the town that should have been involved?
I can't.
You want to?
Yes, that was definitely one of our concerns when we were making and distributing our survey. So we put it in the library, we put it in the Wayne for All Ages Resource Center, but we also have an e-version of our survey. So that is sent out in an email to, like on an email blast to Wayne residents. So we kind of hit as many places as we could in order to get it further distributed.
Does anyone else have any questions that they would like to ask?
Hi, guys. I know kind of similar to, or actually different than our group. So we were in a center where we were with residents on the weekly. So we got to know kind of the same people and establish a population. I know you guys had a little different scenario. So did you find it difficult that you weren't with like a group of like people that you met regularly and you were kind of going off of maybe residents that maybe would come, wouldn't come? Did you find that population difficult to work with this project?
I feel like it was actually the opposite experience because a lot of times, like in our clinicals, we're interacting with patients who are in an acute phase or aren't necessarily independent or living at home. So it was definitely refreshing to interact with elderly individuals who were still completely independent, still were given the resources to have full accessibility to any event they wanted to go to. So it was nice to kind of view that population in a different light because it's a different speed than what we're used to for sure. Usually we're used to like feeding the patients, changing the patients, and it's not patients, it's individuals in a community. So it was funny. The first member that came, she was in her mid-90s, and she came and she sat down, and we read her the prompts, and I said, oh, do you want me to write out one of the prompts for you? And because like that's what we're used to is like doing almost everything for a lot of our patients who are so acutely ill. And she was like, oh no, I got it. And she wrote in like the most beautiful script handwriting, like 10 times better than whatever I would have done for her. So it was just kind of funny to take a step back and like recognize our own bias and like, no, just because we always see elderly patients who are acutely ill, that's our experience usually, there are patients who are completely independent. So it was definitely refreshing to see and easy to make those connections and bonds.
Thank you.
Does anyone else have questions? No? All right, so Professor Wolf's group, I'm going to ask you to start getting yourself up on the stage for me.
Don't forget your phone, right? Thank you.
Christy, is this your phone?
It's very bright.
Do you need this?
Is that ours?
No, I don't
No.
think so.
Okay.
comfortable with. If you guys are gonna click, just click on the computer
way.
over there.
Okay, yeah.
Okay.
Thank you.
And then Nicole's on standby in case it freezes.
You want them up?
I think. What do you think? You guys want the speaker notes out? I don't need them. Does anyone need them?
If you want them, I'll move this over.
We're just gonna stay next to it here. I'm
wanna
just
put it
scared
here?
that's gonna freeze. Yeah,
It's fine, I moved it over. So you can put it there. Okay. Okay. So we can't click this then?
You can.
Oh, we can, and it'll change the screens too? Okay. Do you want to hold it just in case?
I don't know how to look like her.
It's just this. Yeah, I'll do it. It's okay. Yeah.
Yeah, you have to switch it when I start to because I'm not a computer girl.
That's fine.
Ready? All right, so we have Professor Daniel Wolf's group presenting from Overlook Medical Center.
Okay. Good morning, everyone. My name's Haley.
My name's Allie.
My name's Corinne.
I'm Nicole.
I'm Elheli.
And I'm Kayla.
And we're with Professor Wolf at Overlook Medical Center. We're on a neuro, GI, and GU unit. So an introduction to our topic, we use the units of 3, 16, and 31 in our med surgical textbook, and our topic is sepsis. We used it to gather information based on what it is and how it occurs. And we chose sepsis because in our patients and others, it is hard to diagnose. There is no specific test for sepsis, so that being said, each hospital has its own way of identifying when a patient is at risk, or when they have it and when they are in shock. At Overlook Medical Center, where we completed our clinical, we took a look at their tool to see how what our patient had as signs and symptoms aligned with their tool. So at Overlook Medical Center, with a brief look at their tool for sepsis, they have a sepsis BPA, which stands for the Best Practice Advisory. The New Jersey Department of Health defines how hospitals need to screen for sepsis. Sepsis is something that progresses fairly quickly in patients and has a high mortality rate, which makes it diagnosing it as quickly as possible the key to saving lives and reducing morbidity. The sepsis BPA can assist with identification of patients nearing and becoming septic. In EPIC, there is a list of criteria such as diagnosis, symptoms, and labs that will trigger a flag to alert members of the patient's healthcare team that there is a risk that needs attention and action as soon as possible. This will then prompt them to order certain tests, labs, and medications to be proactive against sepsis. So the sepsis BPA tool is very complicated and looks at several criteria, as you can see on the bottom right. The picture on the top right is how it would present in EPIC for a patient at high risk. There are reports that are used that continually evaluate the tool to make sure they are capturing the patient consensus and general population to make sure that they are providing appropriate and actual care. So for our patho of sepsis, sepsis is a life-threatening condition in which the body responds improperly to an infection. And it results when an infection triggers an inflammatory reaction that spreads systemically. And then we have a short video too. Let's see. Oh, that's why. No, it's not gonna play. Is the volume on for the actual computer? If not, it's okay. Okay. It's not going to play, but it's okay. It was just going to give a brief background of what sepsis is, but I have it as an infectious and insult triggers a localized inflammatory reaction that then spills over to cause the systemic symptoms of fever or hypothermia, tachycardia, tachypnea, and either leukocytosis or leukopenia.
Okay, so next we will give a short SBAR on our patient. So our patient was a 65-year-old male who reported to the ER on Wednesday, February 14th with abdominal pain, fever, and chills. He stated that on Monday he had a colonoscopy procedure done. Following the procedure, he was okay and then discharged home. Later that evening, he stated that he became feverish with chills and vomiting. His vital signs showed that he was tachycardic with a mild fever. His labs were then drawn, and an elevation in his white blood cell count and lactic acid was noted. He also had a urine analysis done, and it showed a white blood cell count of greater than 50. A CT scan showed that he had pyelonephritis and also pneumonia. He was then evaluated by the critical care team for sepsis. Following the evaluation, the sepsis protocol was initiated, and he was admitted on Wednesday, the 14th. To give a little bit of background, he has a history of drug use, hypertension. He's a type 2 diabetic with long-term insulin use. He has a history of a diabetic foot infection, multiple UTIs, peripheral vascular disease, and also acute kidney injury. Now to give our assessment. So he was admitted on the 14th, but we completed our assessment on Thursday, the 22nd, so the following week. He was awake, alert, and oriented ×3, and also alert to a situation. He appeared well-nourished, but had a mood and affect that was flat. He appeared jaundiced. A full neural assessment was done, and it was noted that his right eye was reactive, but his left eye was pinpoint. When asked the patient, he said this was his baseline prior to admission, and he does not recall when this occurred. We noted that there was weakness in his upper right extremities and also noted numbness and tingling. His pulses were 1+ bilaterally. His capillary refill was also greater than 2 seconds. The patient also expressed this was his baseline. S1 and S2 sounds were heard with no murmurs, hyperactive bowel sounds, and he stated that his last bowel movement was before his admission. So since his admission, he had no bowel movement. He also had a last urine occurrence was this morning. We also noted a +1 noted bilaterally or noted in his lower extremities with uneven hair distribution. He also had a right below the knee amputation and left pinky toe amputation. Some recommendations that we gathered from this. We will continue to monitor his lab values, his vital signs, make sure to prioritize hand hygiene and proper hygiene, also initiate fall precautions, and notify the healthcare provider of any temperature over 101.
So based on our patient, these were his medical diagnoses, but his principal complaint was severe sepsis, which was due to Klebsiella pneumoniae, and he is a type 2 diabetic without long-term use of insulin.
From this, we then looked at his patient report. So just to give a short list of his current medications, he's on Xanax for his anxiety, Rozepin for antibiotic. He was first put on that when he was admitted, and then later on was put on Zosyn, also an antibiotic. He's on metapropyl to control his blood pressure, heparin, which is an anticoagulant to prevent strokes, his Duoneb for his pneumonia, and then his 2 insulins for his uncontrolled diabetes. To give a few lab values, these are the ones that we found were abnormal. His BUN was increased, his creatinine was increased, his calcium was low, albumin was low, sodium was low, his lactic acid was increased, which we noted before. His glucose was also high, and his white blood cell count, which we also noted before, was increased. Some of the tests that he had done was an X-ray of the chest, lumbar spine, a CT scan of the abdomen and the head, both without contrast. And he also had an MRI of the lumbar sacral spine, and he also had a Doppler procedure done. So following our assessment, we decided to come up with 2 nursing diagnoses for our patient. The first one was infection related to sepsis, as evidenced by his fever, his chills, his elevated white blood cell counts,
and his lactic acid values. The second one we came up was a learning deficit related to his lack of compliance, as evidenced by poor adhesion to recommended treatment, the denial of needing to learn, and the irritability regarding teaching. So from there, we decided to come up with goals, interventions, and outcomes. For our first diagnosis, we said patient's white blood cell count and lactic acid values will be within normal limits and normal values by discharge. Patient will be educated on the importance of showing and reporting signs and symptoms immediately by discharge. Patient will understand the importance of proper hygiene in order to reduce the risk for infection by day 3. Some interventions we will do: provide proper antibiotics according to blood cultures in order to fight off the infection, and provide adequate IV fluids to keep patient well hydrated. The patient will be educated on the expected lab values and specimen culture results. We will demonstrate to him proper hygiene and ways of reducing infection. Our outcomes: the patient will become infection-free, and vital signs and white blood cell counts will be within normal limits. The patient will identify interventions that they can apply to prevent and reduce his risk for infection, and the patient will continuously demonstrate proper hygiene. So for our second nursing diagnosis, the goals that we came up with: well, the patient will be educated on the importance of support systems and accept outside support by discharge. He will be able to identify risk factors of his disease process and how to prevent any worsening. He will actively participate in the learning process and ask questions by day 3. He would demonstrate proper execution of self-care skills such as wound care, insulin administration, and blood pressure monitoring by discharge. And patient will identify barriers to their learning and recognize the potential solutions to these barriers wherever it's possible by day 3. Some interventions we will plan: well, we will create a quiet and adequate learning environment. Our patient will be included in their plan of care and be able to provide suggestions for better regimen success. Patient will use multiple learning platforms for the best learning experience. He will establish priorities first, followed by the less urgent information. And patient will be offered different outside support groups, including pamphlets. Outcomes: our patient will successfully verbalize the importance of understanding the disease process and following treatment. Patient will verbalize their plan of care and know his priorities in order to prevent further complication. And the patient will verbalize different outside support options and demonstrate using other platforms correctly.
So nursing care, physiological integrity. As a nurse, performing care for a patient with sepsis is crucial. Proper care includes frequently assessing vital signs and monitoring for signs of complications. Care also includes controlling the infection by ensuring that all invasive procedures are performed with aseptic technique and frequent hand washing to prevent further complications. Additional care includes collaborating with other team members such as the nutritionalist and infectious disease specialist, as well as monitoring labs such as BUN, creatinine, lactic acid, white blood cells, hemoglobin, hematocrit, and platelet levels. Additional assessments include patient's hemodynamic status, blood sugar, intake and output, and nutrition. Finally, IV fluids, nutrition, and medication should be administered as ordered by the healthcare provider, making sure that antibiotic treatment is delivered timely. Nursing care continued. Psychosocial integrity. It's important to assess the patient's mental status frequently as they are adjusting to major changes in body function. Fighting sepsis can cause mental stress due to the inability to perform usual activities. It is important to keep septic patients as involved with their treatment as possible to allow the patient to feel a sense of independence and value. In addition, it is beneficial to educate the patient on post-sepsis syndrome and what to expect if this occurs. Post-sepsis syndrome is defined as a long-term physical, medical, cognitive, and psychological issue after recovering from sepsis. Ways to prevent post-sepsis syndrome include getting back to regular sleep schedule, performing gentle exercises, and taking precautions to prevent further infections from occurring, such as frequent hand washing. Most importantly, the patient should be instructed to not rush recovery. It is also recommended to speak to loved ones about feelings or emotions or join a group with other individuals also affected by sepsis, such as the Sepsis Alliance Connect, which is a group designed to connect individuals affected by sepsis. It consists of survivors, caregivers, and loved ones of patients with sepsis. The link is listed below. It also may help to read other individual stories with sepsis on the website provided.
Some of the nursing challenges that we may face as nurses when caring for a patient with sepsis are being able to perform rapid assessments. This includes recognizing signs and symptoms of sepsis, fever, hypothermia, tachycardia, altered mental status, difficulty breathing, skin changes, maintaining infection control. This includes proper hand hygiene and use of protective gear, effective communication, coordinating care among healthcare members, including doctor, dietitian, OT, PT, and social workers, and nutritionists, continuous monitoring of vital signs, fluid balance, and laboratory values, any changes from the patient's baseline, and lastly, medication management and adherence, also monitoring for potential adverse effects and drug interaction. For our specific patient, our number one nursing challenge would be medication management and adherence, because unfortunately, our patient chose to leave the hospital and sign an AMA, discharge against medical advice, without completing his treatment.
And for nursing solutions, we want to educate the patient on the 3 Ds, and we came up with this: diabetes, drugs, and diet. What we want to tell the patient what diabetes is and what it looks like when it's uncontrolled, the drugs they are taking, and how that helps to monitor and help with those glucose levels. And we want to inform them how their diet impact their journey with diabetes. For the second point, we have monitoring glucose levels and CBC. Because the patient is diabetic, we want to be constantly monitoring their glucose levels as nurses, because the patient status is our priority. If the glucose levels are uncontrolled, do we need another round of insulin? Are they not taking their medications? If the CBC, I'm sorry. If they're still suffering from the infection, we can see that in the CBC. For number 3, we have documenting at bedside. That's why we have the portable computers in the hospital, because documenting at bedside increases the patient information accuracy, and that is essential to the patient's care, because we are not at the hospital 24/7. We need to document properly, because the next nurse, they're coming in and they're using our information to take care of the patient. If we don't have accurate information, that could encourage malpractice, which we do not want. And last but not least, we are collaborating with the interprofessionals. We, as nurses, we have to understand our scope of practice. When we understand and acknowledge it, we can know when to call for help. So we're reaching out to our dietitians and nutritionists to help coordinate the best meal plan for our patient. So we're looking at diets that are, low in carbs and also rich in immunity building foods. And also we are reaching out to occupational therapists and social workers, because our patients have their own goals. So we need people to help our patient get back on their feet and to provide them with the best resources in their area to keep them healthy. Thank you.
Okay, so now we have health promotion and maintenance focusing on sepsis. So in order to maintain and prevent sepsis, we want to be able to identify patients that are at risk for dehydration, compare urine output and fluid intake, weigh the patient and check for daily changes in daily weight. We want to assess for shock in any patients that develop a change in mental status, an increase in pain, or an increase in anxiety. We are also going to educate our patients on signs and symptoms of shock after invasive procedures. In order to prevent sepsis, we also want to educate our patients on resources that are available to promote awareness of sepsis, such as the CDC's campaign of Get Ahead of Sepsis.
This campaign identifies what sepsis is, who is at risk, the signs and symptoms, as well as what the patient can do to reduce their risk. It also identifies what a healthcare professional can do for their patients with sepsis. Continuing with health promotion and maintenance, we are focusing on diabetes as well. With this patient, we are going to educate on glucose monitoring. We are also going to advise a healthy lifestyle and promote regular physical activity according to his tolerance. We also want to focus on stress management and reduction. We can use support groups to help with stress or a wide variety of options to help with stress management like meditation. We also want to educate on drug adherence and emphasize the importance of drug therapy to lower blood glucose levels. By following all these health promotion and maintenance techniques, we can prevent further infection or future infections. And then this was just an Alcohol Anonymous group. It's just a support group that if someone is interested in joining, this is just one. And we have more information on it if anyone is interested. And that is all.
All right. Does anybody have any questions for them? Oh, good.
It was a great job. I'm one of the clinical faculty. Just a quick question. So and I apologize if I missed this. But when you listed the labs, you didn't put the cultures, the blood cultures. So it would have been nice with sepsis to see the organism that was growing, because it determines which antibiotic use. So just something to think about in the future.
Were you asking the name of the bacteria or just how it was
So
growing?
you didn't really mention, like in the labs, the blood cultures.
Okay.
And the growth.
Right.
So you did your assessment, like a week later, so blood cultures definitely should have been drawn immediately upon admission.
Mhm.
And then the growth would develop probably 48 hours later. And that determines the antibiotic use.
Right.
So I just would have liked to know the organism.
Okay.
Anybody else have any questions? Oh, Professor DeHern, what's up?
Hi. Hi, I'm Professor DeHern. I just have a comment, because in the beginning you spoke to the best practice advisories. And I'm wondering, or I'm hoping, as students, as you move into your practice, you'll think about how AI can really assist with those best practice advisories and really help us sort out those patients quickly.
Thank you. Anybody else have any questions, comments? Erna. All right.
I think you guys did such a good job, but I just had to ask, why did the patient sign an AMA?
So when we did our assessment, we noticed that he really wasn't interested in, not like us assessing him, but interested in the care that he was receiving. He kind of didn't see a problem with what was occurring. So after our assessment and we did look at everything going on, he was really reluctant to leave. He still didn't want any care. He still wasn't going to be compliant with his insulin use. So basically everything we were doing, he was kind of just yeah, okay. So it's more of just he didn't really want to receive care on what was going on with him. So he signed himself out.
Also, I'd just like to note that he did say that prior to his procedure on his colonoscopy on Monday, he had done a line of coke. So it was also a problem. He has a history of drug use. So we thought part of it was that he wanted to go home and continue to use the drugs he was using. So obviously he can't do that in the hospital.
Okay. Dr. Byrne.
Hi, what a wonderful job. I was very impressed, especially with your last graphic slide for Alcoholics Anonymous. Had you looked into the lab work? Did they actually do any toxicology testing on your patient? Well, that means drugs or alcohol.
Yeah.
No, okay, so that might be something as you move forward in your career to think about. I heard you also mention cocaine now as I was walking up. So there we are, we're simpatico. It's a very difficult disease, and it might be underlying a lot of these presentations. So there's also Nar-Anon. So there's Alcoholics Anonymous, and Narcotics Anonymous, and a lot of help out there for this gentleman and others. Thank you on a great presentation.
They want to be off the hook. Is Professor Hawkins' group ready? Good job. Because I don't even know how do I make this work? Hey, Dan, it's frozen. So we're not going to ask
All right,
them?
they're going right now.
Works? Okay. All right, so we had a little change to our agenda. So Dr. Kozlowski's group's going to go now, and then we'll bring back up Professor Hawkins' group in a few minutes.
Can somebody switch this? Hold on. Thank you. Good morning. So this is our project, Commit to Being Fit. Our community was at the Marion Manor across the street. It is, did it change? I don't know. It is made up of independent senior citizens aged 55 and above. As part of the Section 8 project-based rental assistance program provided by the U.S. Department of Housing and Urban Development, they offer affordable housing where rent is capped at 30% of each resident's income. Many of our residents face mobility issues, with 30% of them using assistive devices like canes and walkers. We recognize the importance of staying active, so we've implemented an exercise program tailored to their needs. They were very eager to participate and to maintain their mobility and vitality.
So one of the most crucial steps in developing our project was collaboration. So we had to engage with residents and the social worker Lisa at Marion Manor in order to identify a common concern among the community at hand. We also worked in collaboration with Professor Dorothy Kozlowski to develop a structure of the workout program as well as setting dates. Specific positions and sets of responsibilities were assigned. So the janitorial staff was responsible for setting up the seats and setting in order to be safe for the exercise program. Professor Dorothy Kozlowski purchased snacks and water bottles for the residents in order to engage them a little more. And as for the students, 2 conducted the exercise session, 2 handed out water bottles and snacks, and 2 ensured safety during the program by aiding residents in standing and sitting. So the timeline. First, we started off with the assessment of the community in order to identify the common concern by brainstorming and collaboration. We also got some feedback on the topic by residents during our blood pressure screenings in the morning. We also developed the structure and scheduling of the exercise program, and we decided on 4 weeks total. February 15th being the first day of our educational presentation, February 22nd, February 29th, and March 21st being the exercise class being conducted. We got approval by Lisa, the social worker, and Professor Kozlowski for implementation. Next, we set roles and responsibilities and conducted the 4 sessions of our exercise program. Last but not least, we did an evaluation where we measured the outcomes and provided a feedback survey for the residents to fill out.
So the problem statement we came up with was senior residents with limited mobility who are often restricted to their rooms due to fear of injuring themselves or feeling socially isolated. Benefits of exercise. The Healthy People 2030 objective we identified was to increase the portion of older adults with physical or cognitive health problems who get physical activity. Some research articles we reviewed was a 2021 meta-analysis of 650 subjects that showed that exercise is an effective intervention in reducing falls in older adults by 36%. Another 2023 meta-analysis of 10 studies showed that regular aerobic exercise improves cognitive function in older adults. So to start off the program, we held an informational meeting about the 3 exercise programs offered. And at this meeting, we provided coffee and donuts to increase participation. And we also made flyers about the program and posted it throughout the building. To further increase participation, we made multiple phone calls to residents, left voicemail messages, and reminded residents during blood pressure screenings. And this is a picture of the flyer. And we made sure the font was big so they could read it and colorful.
All right, so our program plan, the goal of the program is to improve body strength to reduce falls and improve the residents' mood with 30 minutes of exercises. During the program, we played music, the residents requested. The exercise include lateral raises, squats, calf raises, bicep curls, tricep extensions with water bottles. We actually taped water bottles shut to use as weights for the residents. We also included stretching, joint mobility, and breathing exercises at the end to sort of like finish it off. We took a 5-minute break halfway through the program for residents to drink water and have a snack and rest. Some challenges we faced is incorporating exercises to accommodate residents in a wheelchair and those with full range of motion. To overcome this challenge, we incorporated standing exercises and modified sitting exercises. So like Adriana mentioned, 2 students demonstrated the exercises and the rest of the students walked around the community room and assisted residents who needed help getting out of chairs, encouraging them to take breaks if they needed, and keeping assistive devices nearby.
So in Marion Manor, we had some proficiency challenges that we face, 1 being language comprehension, 2 being inclusivity, 3 being a hearing deficit, and 4 being poor eyesight. So as Lisa, the social worker, and our professor have educated to us that in the recent last 2 years, Spanish speakers have been a greater population. English was definitely the main primary language, but Spanish speakers have been coming more to enrolling more in the facility. Fortunately, we had 3 Spanish speakers in our group, me, Maria, and Adriana, who spoke Spanish, and just helped them throughout the process. To ensure inclusivity, we translated all paperwork into Spanish as well so that they can participate, and we can also get more participants in our exercise program. We did one-on-one with the residents verbally to amplify paperwork in case they couldn't hear what we were talking about. We would sit next to them, talk them through the paperwork. And we provided verbal reinforcement to those who struggle with sight and hearing. So once again, we just do the one-on-one and just assist. So our implementation, this is kind of how our program went through. February 15th, we did our presentation to as much members as possible. We emphasized on safety, the benefits, the purpose, what to expect in the next couple days, the dates, the proper timeline. And then on February 22nd was the first day of our exercise program, in which we gained 15 participants, and it was a duration of 30 minutes with a 5-minute break. February 29th was our second day. We got 15 participants again, same 30-minute duration with a 5-minute break. And March 21st was our third day. We got 13 participants, but this was week missing. I think it was spring break, so we had a little decrease, maybe because of the inconsistency, but we got it.
All right, good morning, everybody. I'm going to be doing the evaluation portion of our project. So feedback was encouraged throughout the 3 weeks. This was mostly verbal feedback, and it was recorded as quotes throughout our project. Any feedback that we kind of got during this time was we were discussing throughout each program week. And it kind of was the basis of whether we were going to do changes or adjust anything. Our formal written feedback was obtained through printed out surveys. I have a picture of the survey on the side. This consisted of 6 questions. These 6 questions kind of focused on the number of sessions attended, if the program met expectations, if the residents felt safe and comfortable performing the exercises, any reports of improvement after attending, any difficult or challenges faced during the program, and their overall satisfaction. So out of the 9 residents that attended all 3 sessions, 8 of them said that they saw significant improvements. These improvements were walking more around the building, doing some of the exercises we actually did at home. The participants who did not go through all 3 sessions, they stated that they saw some or no improvement. However, there was a common sentiment that they wish that they had gone through all 3 weeks. One gentleman that we spoke to said that he hasn't worked out in 15 years, so any movement is really good movement. This was something that we saw throughout the residents at Marion Manor. Some of them haven't worked out for years, and some of them were implementing their physical therapy or really were active before they came to the manor. So I have a chart here. These chart kind of focused on two questions that were on the surveys, the number of sessions attended and their satisfaction rate. As you can see here that the residents that attended all 3 sessions, they have a higher incidence of being most satisfied to satisfied. The lower scores indicated that they didn't really attend all sessions. So there was a positive correlation between the satisfaction scores and the full implementation of our program. There was a total of 13 written surveys that we collected. This was kind of an even number of the people that kind of attended. We had 15 in the first, 15 in the second, and 13 in the last one. Our final thoughts. Overall, the feedback was positive. Speaking to the residents after the exercise program, they were kind of wondering if we're going to implement it again. They were very excited to see us every time that we came by. The residents of Marion Manor enjoyed physical, emotional, and social benefits from the implementation of the program. However, upon evaluation of the program, it would be most beneficial to separate the residents based on the degree of functional mobility to optimize the benefits of the exercise program and challenge them appropriately. Something that we would kind of like define it based on would be sitting and walking mobility and assisted device usage. So here are some photographs that we obtained during our exercise programs. Consent was obtained for these photographs as well. So you can see that we're kind of all throughout there. They're really happy and everything, which is great. And yeah, does anybody have any questions?
Great job, guys. Any discussion on sustaining the exercise program at Marion Manor? Do they have plans to continue to offer exercise?
The only issue about that would be kind of having someone like Codwell that's coming outsourcing to the Marion Manor. When we spoke to Lisa, they said that previously they had something similar to like an exercise program, but there wasn't that much like follow through. So it'd be more communicating with like Lisa and kind of managing that. But they really do enjoy the Codwell students. They ask for us anytime they see like our really bright red scrubs. They're like, "Oh my God, you're here! Like, let's take my blood pressure and everything." So, yeah.
Does anybody else have any questions for them? You're letting them off the hook? All right, good job, guys. Professor Falcone's group, I'm going to have you.
Okay, try now.
Oh, okay.
Good morning, faculties, students, and guests. My name is Olayemi Oduola.
Hi, my name is Catherine. My name is Laura.
My name is Gianna.
My name is Brianna.
Our clinical rotation this semester was on Devino 1, the orthopedic unit at Morristown Medical Center with the Professor Falcone. And our presentation today is focused mainly on the concept of care for alcoholic patients with rhabdomyolysis. And our primary aim for this project was to dissect the root cause of the patient's diagnosis and also to apply evidence-based practice to our care. And we chose this topic and this patient due to a combination of factors that the patient presented with. Both psychosocial and medical factors affected this patient. She had expressed that she had a lack of familial support as well as an alcohol problem, and this largely contributed to her fracture and her diagnosis of rhabdomyolysis.
Okay, so now I'm just gonna go over the S-bar that we use to break down our patient. So for situation, patient is a 67-year-old female that was transferred to an outside facility. She had fallen off of her bed and was on the floor for an unknown amount of time. She suffered a left femur fracture from the fall, and she did not lose consciousness during or after the fall, but she did state that she consumed alcohol up until her fall. And just for background, she does state that she drinks daily about 27 glasses of wine per week, and she does use a walker or a wheelchair to get around the house due to her, she claims, laziness, and because of that, she has frequent falls. 1 year ago, she also stated she had a left hip closed reduction done with pinning. There were potential falls during this time. She did state that there is family tension at home, and the patient did reveal suicidal ideations, and upon admission was placed on a one-on-one observation when admitted. The patient was alert in terms of the assessment. She was awake and oriented ×4. Her skin color was a bit grayish, and she appeared to be malnourished. Her creatinine kinase CK levels was 1984, which suggests acute rhabdo. And just for reference, the regular range is usually around like 22 to like 198, and obviously that's really high for her. This level suggests an indicator of muscle wasting, and her vital signs were stable though, and she appeared confused when she was admitted. And upon admission, the CWA-AR test was administered, which can be referenced on the handout that we passed out. The patient has no complaints of chest pain or claims of any loss of consciousness. Her troponin levels are negative for cardiac relations to falls. So the CWA is on the bottom. It says that it's not used as a diagnostic tool, but it does assist in patients in monitoring and managing kind of withdrawal to alcohol. So in terms of recommendation, the patient is at risk for bleeding due to high vascular nature of a long bone fracture, and impaired mobility recommendations are to follow in the nursing assessment.
So I'm just going to go over the pathophysiology of rhabdomyolysis. So what is rhabdomyolysis? Rhabdomyolysis is a condition characterized by the breakdown of skeletal muscle tissue, leading to release of intracellular contents into the bloodstream. If you turn your paper around that we gave you, there's like a little image kind of explaining it. The breakdown of muscle tissue releases myoglobin, electrolytes such as potassium and phosphate, and enzymes such as creatinine, kinases into the bloodstream. Rhabdomyolysis typically occurs when there is an imbalance between muscle cell injury and repair mechanisms. So how does alcohol abuse lead to rhabdomyolysis? Alcohol abuse can lead to rhabdomyolysis through various mechanisms. Excessive alcohol consumption can impair judgment and coordination, increasing the likelihood of accident or falls that can cause muscle damage. Alcohol abuse can cause muscle weakness and fatigue, leading to increased susceptibility to injury during physical activity. And chronic alcohol abuse can lead to nutritional deficiencies such as protein, iron, B, vitamins, and vitamin D, which are important nutrients in building and maintaining muscles. And alcohol abuse can lead to the inappropriate absorption of these vitamins. So the main goal for a patient with rhabdomyolysis would be to prevent kidney damage by minimizing the toxic effects of myoglobin and other muscle breakdown products on the kidneys. Early recognition and prompt intervention are crucial to prevent complication and improve outcomes. So how do we reduce kidney damage? Adequate hydration helps to maintain renal perfusion and urine flow, facilitating the clearance of myoglobin and other toxic substances from the kidneys. Fluid resuscitation also helps to prevent dehydration and electrolyte imbalances, which can exacerbate kidney injury. So this was her medication list. So she was on multiple pain meds such as morphine, oxycodone, Tylenol, ibuprofen, and Aleve. And she was also getting vitamin supplements, oral calcium, folic acid, B12 daily. And I just want to point out this med is called naltrexone. It's Depate. So this is an opiate antagonist, and it works by blocking the mu opioid receptor. And basically, this drug, it binds to endorphin receptors in the body and blocks the effect and feelings of alcohol, and it works to reduce alcohol cravings. So they gave this to her because of her alcohol dependency. So some nursing diagnoses that we came up with for our patient, the first one being risk for falls related to fractures and alcohol abuse. So some interventions for this patient, we want to monitor the patient closely for signs of alcohol intoxication or withdrawal, such as confusion, agitation, or tremors, and implement appropriate interventions as needed for that. We also want to implement fall prevention measures, such as keeping the bed in the lowest position, using bed alarms or motion sensors, and providing assistance with ambulation and transfer. We want to ensure that the patient's environment is free of hazards and adequately lit to promote visibility and reduce the risk of tripping or falling. We want to encourage the patient to use assistive devices such as walkers or canes as prescribed to support mobility and stability. We want to educate the patient about the importance of avoiding alcohol consumption and adhering to the prescribed medication and treatment to prevent further complications. The second nursing diagnosis that we came up with for our patient was impaired mobility related to fractures and alcohol abuse as well. We want to provide pain management interventions such as pharmacological and non-pharmacological measures to help alleviate discomfort facilities. So some non-pharmacological measures would be positioning the patient and providing ice packs for her as she did have a femur fracture. We want to collaborate with physical therapists to develop a personalized rehab plan focusing on strengthening exercises, range of motion activities, and gait training. We also want to assist the patient with transferring and positioning safely to prevent further injury and promote optimal alignment of the fractured limb. We want to educate the patient and family members about the importance of adhering to prescribed weight-bearing restrictions and activity limitations to avoid exacerbating the femur fracture. And lastly, we want to encourage the patient to engage in nutritional therapy to support muscle recovery and promote overall healing.
Okay, so the third diagnosis that we thought up was risk for self-directed violence related to suicidal ideations. So with that, the nursing interventions would be to establish a therapeutic rapport with the patient based on empathy, active listening, and non-judgmental support to facilitate open communication and trust. We would also conduct regular assessments of suicidal ideations and monitor changes in mood, behavior, and risk factors over time. We would also collaborate with the interdisciplinary team, including psychiatrists, psychologists, and social workers to develop a comprehensive treatment plan addressing the patient's mental health needs. In addition, we would implement suicide precautions such as close observation, removal of potential means of self-harm, and restriction of access to harmful substances or objects. So she was on one-to-one observation upon admission, but when she was reevaluated, she was taken off of the one-to-one observation based on the psychiatric evaluation that was conducted. And finally, we would encourage the patient to engage in therapeutic activities such as individual or group therapy, cognitive behavioral techniques, relaxation exercises, or expressive art therapies to enhance coping skills and resilience.
And for our nursing care through the continuum, we focused on three main aspects: physiological integrity, pharmacological interventions, as well as the patient's psychosocial integrity. So first, for the patient's physiological integrity, we looked at her basic care and comfort needs. With a focus on her mobility, we inferred that this patient would have to work with physical therapy to improve on mobility, because this largely contributed to her fracture and diagnosis of rhabdo. And here we really see the interdisciplinary collaboration coming into play. Secondly, for our pharmacological interventions, pain was the main concern with this patient, especially being post-op. She was in a lot of pain, and that as well caused impaired mobility. So managing her pain effectively was a significant part of our nursing care, and we would also consult with pain management as well to see how best this could be achieved. Last but definitely not least, maintaining our patients' psychosocial integrity was also part of our care. We trying to make sure that her mental, social, and emotional needs were being met. We would focus on her depression, alcohol abuse, and coping skills. Especially, we mentioned that she had family tension at home, which she had described. She was really lacking a good support system. So we would educate on the significance of also strictly adhering to her psych medication regimen, and we would provide resources for alcohol abuse support groups, such as Alcohol Anonymous, given that the patient presented first with an alcohol problem. Lastly, we would educate her on dialectical behavioral therapy, and a psych consult will really be helpful in this aspect. DBT, that is dialectical behavioral therapy, is a type of cognitive behavioral therapy that can be used to treat various mental health conditions through the use of skills like core mindfulness, distress tolerance, emotion regulation, and also self-validation.
Okay, so now we're just gonna go through some of the nursing challenges that we found that we might have faced or have faced while with the patient. So in terms of interdisciplinary involvement, social services would involve trying to find someone that would actually accept her post-discharge since she doesn't have that support system at home. We'd also involve a psych therapist in terms of her suicidal ideation, nutritionist and dietitian related to her alcoholism, and some discharge planning conflicts that might just involve ensuring that the regimen is being complied with post-discharge and like her home care. And then the physical and occupational therapist just to kind of like take care of her ADLs, ensure that there's proper movement to promote healing. And something that we actually got to experience and actually watch was interdisciplinary rounds at our unit. So specifically for the Morristown Ortho unit, it involves various roles within the unit that offer continual support post-discharge for our patients and the regulation of certain resources. And when I asked the nurse that actually participated in on the day that we actually got to witness it, they occur like every weekday, not on weekends. And they basically just go through all of the patients and ensure that they're all being taken care of and what's going on with them. It usually involves like PT, PAs and such. So in terms of patient and family challenges that we might face, so overall just non-compliance to the regimen, because the patient does admit to drinking, but she doesn't believe she's an alcoholic because she claims that she doesn't want to hurt anyone, but she still is a danger to herself physically and mentally, despite that, what she claims. And because of that alcoholism, she has poor nutrition and neglect of health. And because of that, she needs that long-term care. She mentioned she had family tension and no support system at home, so that's another challenge. Her past procedure also do play a part. She had a close reduction right hip with peening about a year ago, and then again, the left femur ORIF. And just adjusting to the new routine, that would just be a challenge for her overall, especially with what she's going through. And again, she did claim she was not an alcoholic, but is still a danger to herself.
So for the nursing challenges, we did want to find possible solutions, and the one solution that we chose was fall prevention. Fall prevention in regards to her chronic alcohol use, because, fall prevention not only within the hospital stay, but as well as upon discharge. So why falls? Her risk falls are due to the alcohol use, which increase her susceptibility to injury, which increase frequent falls. And she has past procedures due to falls, so that would increase her impaired mobility. And without the use of a walker wheelchair, she will continue with more injuries. So we wanted fall prevention items. So to identify fall risk items, which will be clutters, we would keep the bed lowered. We would have personal items within reach. And then we would teach the patient how to use the call light while ensuring as well that there is appropriate lighting within the room. And then the patient would also be able to ambulate with assistance. The outcome and benefits would be that the patient would remain free of falls, and we would do kind of teach back so that the patient will be able to identify risk factors that risk factors within the settings that pose them at risk for falls, which are clutters, inappropriate footwear. The evidence-based practice that we use is fall preventions in hospitalized patients, evaluation through the nursing outcomes classifications, or NOC, from Fridas Lucia. So their study was a cross-sectional study conducted in a Brazilian hospital. In the study, they aimed to evaluate fall prevention strategies within a hospital setting. So with the NOC, they wanted to access the effectiveness of interventions. So they identified risk factors as age, mobility limitations, and medication effect. The sample consisted of 68 patients from July 2017 to August of 2018. They used the Morse Fall scale, and the scale consisted of if it was greater than 45, then the patient was at greater risk for falls. The patient received evaluations 24 hours apart in sets of 3. So what the study found was that knowledge deficit was the biggest risk for falls, without the patient being educated on the correct use of equipment, the correct use or identification of fall items, which are like the clutters, then that would mean that they would be an increased risk for falls. So the importance of showing patients or just educating throughout, not only us as future nurses, would just be to include like environmental and preventative measures. Environmental measures would be ensuring that everything is we would need to reinforce educational measures for fall prevention. The greater the patient knowledge is on fall prevention, the better. These are the policies from Atlantic Health Center, specifically from their website. So they would wear slipper shoes with non-slip soles. They would turn on the lights in the room and wear eyeglasses if needed to see clearly. If the patient is permitted to get out of bed, then we would assist and then educate the patient to sit at the bedside standing, rise slowly, and walk out of bed. We would educate the patient not to lean or support themselves on rolling objects, which would be the IV poles, bedside table. And we would also just have PT, OT, or interdisciplinary care with the patient within their hospital stay.
To promote health and maintain it, we looked into the Joint Commission's national patient safety goals, combined with our patient's history of alcohol consumption, her fall history, and now her fracture. She's obviously a very high fall risk, so there have to be steps put in place to prevent her from further injury. Patient safety goal 9, reduce the risk of patient and resident harm resulting from falls, addresses this concern. Certain interventions that the Joint Commission listed include obtaining fall history, medication history, and their history of alcohol use. Healthcare professionals should also assess the patient's gait, balance, and any use of assistive devices. Lastly, it is important to educate the patient, family, and staff members on fall prevention. Simple things such as teaching about their environment and removing things such as rugs or cords that lay on the floor make a big difference in these patients. And also keeping the call bell close to them and their personal belongings close to them so that they're not inclined to get out of bed and get it on their own. When looking at a patient who has a history of excessive alcohol use, it is important to monitor their behavior as well as teach them the effects it could have on their bodies. For these patients, we want to examine their coping mechanisms and their support systems. Those who lack efficient coping skills and support are more vulnerable to these substance use. So we also want to look at how it affects their day-to-day, including their mood, changes in sleep, activities of daily living, and social and occupational dysfunction. In terms of elements of performance, patient education is a big factor in promoting the patient's health. We want to educate the multiple ways alcohol can affect the body, and we also want to encourage healthy coping skills, such as going to support groups and promoting communication of feelings of fear and anxiety that the patient might be facing. Lastly, we should always collaborate with other healthcare professionals, such as social workers and other mental health workers, to approach any underlying issues that could provoke unhealthy drinking or substance habits. This is especially important upon discharge to reduce the chance of readmission in the hospital. That's it.
Okay, great job. Professor Yulee has a question for you.
If you go back to the pain medications slide.
It's a little far back.
Okay, one of those, well, there's a few. Meds are for rhabdo. So she has alcoholism and she has rhabdo. But there's one medication on there that should not be given with rhabdo because of the side effects. Do you know which ones that is? Okay. Do you have an answer? So when you
is it ibuprofen or Tylenol?
It's ibuprofen.
Okay.
Do you know why?
The effects it has on the kidney.
Excellent. NSAID should not.
Ooh. I got a lot of questions. I like it.
Hello. Great job on a complicated patient. I want to stay on this page too. I saw that the 3 priority diagnoses that you have, and I agree that they are all important. And this patient had, there were psychosocial issues, there's physiological issues, and there are mental health issues. So very complicated patient. However, you mentioned that pain was very difficult to control. And as Professor Yulee pointed out, well, not only the ibuprofen, but Aleve, they're both nonsteroidal anti-inflammatories, which if you have rhabdo, your kidneys are impacted. That's not going to be a drug of choice, which is unfortunate because nonsteroidal anti-inflammatories are excellent for bone pain. And if she has alcohol-related issues, misuse, then Tylenol is also not going to be a drug that you want to have a lot of in your system. So that's unfortunate. However, she is also getting an opioid antagonist. So that will counteract the effects of both oxycodone and morphine. So she's getting no pain relief, basically. And so, I would possibly have put pain perhaps still higher. You mentioned that she was having difficulty controlling pain, and I'm not surprised. So I would probably put that a little bit higher on the list of priorities. And I recognize that you mentioned getting a pain consult, and I think that would be the way that we would want to go, because you absolutely need someone who has expertise in what to do, because the naltrexone will help with someone who's got alcohol abuse, but you can't use it if someone's on opioids. You have to be off opioids. So she's got some pain medicine that is not going to get to the pain receptors, and then the non-opioids she can't use in significant amounts. So that's going to impact her mobility, that's going to impact her mood, that's going to impact everything if she's still uncomfortable. So.
Thank you. Does anybody else have a question for them? You do?
1 second, I'm going to grab it here and then I'm coming up.
With regards to the interdisciplinary team, do we know, and this is a follow-up from Dr. Boreal's question, do we know if pain management was a part of her interdisciplinary team? Maybe I missed that on this slide. I'm not sure.
So like when we actually got to like witness the interdisciplinary rounds, we saw some like professionals, but we didn't see specifically someone for pain management, if I'm not mistaken, but we did see like heads of departments and like PT and OT, but not specifically pain management, if I'm not mistaken.
Okay.
Yes, thank you so much for a beautiful presentation on a very complex woman. We're all learning so much today, in my opinion. With regard to this woman, though, has anyone on the team in the hospital discussed or evaluated her bone density?
Do you mean like the DEXA scan?
Oh, that's kind of like what I mean, yeah.
Yes.
Does she have osteopenia, osteoporosis?
Yeah, so like upon assessment, I don't think that was like one of the things that we like actually got, or if it was conducted actually.
Right.
But it definitely probably would have been like a recommended like nursing intervention, just to make
Well,
sure.
to the team. So if you're talking about interdisciplinary, that's a wonderful learning experience. It's interesting they're giving calcium, but it might be missing the mark on this particular patient. Great job, really great job.
Just a quick comment. So if you think about like we're just clinical is one day, right? So it's just a snapshot into, this patient who's been there for quite some time. So when our students did the evaluation and picked this patient, it was really due to the complexity of the diagnoses. And the DEP aid is mentioned, but I don't believe that she was on DEP aid in the hospital. I believe that she came in with it because she has a history of alcohol abuse. It was put on hold after her surgery. So the reason why it's on here is because we wanted to talk about it, or the students wanted to talk about it, because it's not a familiar drug. Does that make sense? Great, thank you.
Does anybody else have a question for them? They're sweating.
A little bit.
All right, come
Okay.
Okay, Professor Hawkins group.
I'm gonna have you guys.
Oh, smart man. Smart.
There you go. Are we ready?
Yeah.
Oh.
Hello, we're Professor Hawkins' group, and we went to Cranes Mill.
So a little bit about Cranes Mill. It's a retirement care community which is located in West Caldwell. It offers luxurious housing with a maintenance-free lifestyle with a range of different healthcare options within the community. Different types of living options are continuous care, independent living, assisted living, and memory support. And at Cranes Mill, they try to replicate the experiences of living in a community with amenities such as a theater, private restaurant, and fitness center, and more.
So what are the goals, outcomes, and learning outcomes? So our goal was to increase social interaction between the residents and promote physical activity, dexterity, and opportunities for reminiscing. The outcomes, significant rise in social interaction among the residents to increase physical activity levels, improve dexterity, and more opportunities for the residents to share and recall cherished memories with each other. And the learning outcomes was to enhance social interaction, provide physical and cognitive stimulation, and provide the residents with a satisfying and enjoyable experience.
So for our problem statement, we stated that among elderly residents in assisted living communities, the lack of recreational and social activities can contribute to feelings of isolation, loneliness, and decreased quality of life. Introducing carnivals as a form of entertainment can help address these issues by enhancing social engagement. These activities can also lead to the release of endorphins, thereby fostering happiness and overall satisfaction among older adults in assisted living facilities.
I did the collaboration with Cranes Mill Agency. We presented the carnival event idea to Rachel Texiera, the director of nursing at Cranes Mill, and she agreed to our plan. The staff in Cranes Mill heavily encouraged us to do activities that would be physical and specifically entertaining to the residents. We made flyers a week in advance with colorful lettering and background, large fonts, and activities listed for easy reading. So here's a picture of the flyer that was made. We also encouraged families to attend our event. The event was to take place at Cranes Mill at the Assisted Living Activity Room from 10 a.m. to 2 p.m. on April 11th. The benefits that we explained to the Director of Nursing was promoting mental health, so promoting mood, socialization, and memory, as well as physical health, so promoting dexterity and active range of motion exercises.
Okay, so for this group, we were specifically mostly on the unit that was nursing or assisted living. Our group at Cranes Mill is a little more specific. We do know from community that age is a social determinant of health, and usually with the elderly in these nursing homes, they are considered a vulnerable community. But Cranes Mill is a little different. They actually have quite a lot of resources available to them. So when we were doing our assessment of this population, it was really more reaching out to the residents and speaking with them and figuring out what they felt they were missing in their daily lives here at the community, because they do have a wide variety of opportunities and groups and activities available to them already. So what did they feel that they were missing? And one of the biggest things that we found when speaking to the residents, that the consequences of COVID-19 from the past few years were still visibly prevalent in the community. A lot of the residents were still very scared and not socializing the way they used to. And residents that have been there for years at a time found that it hadn't really been the same since COVID occurred. Not as many patients or residents socialized like they used to, coming out for activities, and there was apprehension to fully re-socializing. They stated that since the pandemic, they didn't feel the same, and some residents didn't come out for groups at all anymore. Residents were looking for more within the environment despite what's already offered. So things that they could do, they had a lot of activities already, like they had church on weekly basis or masses that came in. They had activities in the afternoon that were available to them, and exercise groups were all done daily in the morning. So finding something for them to do. Routine is great, but a lot of the residents said that sometimes it becomes tedious, that they do some of the same things every single day. So something that was a little more fun and engaging for them to do, that's what we looked for during our assessment. They explained that they were looking actually for a fun and even nostalgic activities, while others searched for mind-stimulating activities as well.
So some of the things that we implemented were just having different games, craft activities, and snacks. So for example, for some of the games we had to promote their dexterity was inflatable bowling, baseball, cornhole, and we had large yard pong where they could like toss the ball and things like that. We had other table games for residents that may not want to play those types of games with ping pong balls and puzzles. And in the afternoon portion, we did 1950s, 60s, and 70s trivia, and we did The Price is Right and Jeopardy. They seemed to love that one. And then the craft activities that we did is they got to decorate their own spring door signs and put them up in their rooms or on their doors. We had a large collaborative coloring sheet that they could all do at the same time if they chose to. And then they had do-it-yourself friendship bracelets, which they seemed to enjoy as well. For snacks, they had cotton candy, chips, cookies. We had iced tea, lemonade, and water. So we tried to keep all of our activities, snacks, crafts, all of that as similar to a carnival as we could indoors.
Research shows that community group activities such as our carnival project enhance socialization, memory, a sense of belonging, bonding, and mostly foster feelings of being cared for and listened to. This is evidenced by the fact that it was the first event since COVID-19 that our residents were in attendance. The carnival event, according to the aides and the nurses, brought overall happiness and fostered a stronger sense of community and bonding among the residents.
To assess our population's literacy and language proficiency, we had to identify common traits across our population that would give us an understanding of how well our patients could read, write, speak, and comprehend words or symbols. So the factors that contributed to our population's literacy and language proficiency were they were all college educated, spoke English fluently, and could understand and read English at a 12th grade level. But we also found some factors that hindered their language and literacy proficiency, such as difficulty hearing, vision problems, and cognitive impairments, such as dementia. So based on our language and literacy data, we decided to use a survey to evaluate outcomes. We made sure it was at a 4th grade reading level. It was typed in bold print letters and had short, straightforward questions. These features made the survey easy to complete and really easy to understand.
So we did have some challenges with our project and how we overcame them. So we really wanted to make sure that our project, that with our activities that we chose, they were appropriate for indoor and outdoor activities depending on the weather. One issue that we did get from feedback from our residents was that they felt that some of the activities were not challenging enough or that they felt that they were too easy. So then we tried to work with that to see how we could make it a little better for them. And then something else that we faced during this is our residents at Cranes Mill do go on a very strict routine. They have like exercises at 10 a.m. They sometimes do like chair exercises at 12. They do like lunch. So our carnival kind of interfered with that routine. So when we were doing our activities in the morning, they kind of did feel that we were kind of messing up the routine a little bit. So they were a little apprehensive at first. So we worked with the activity coordinator at Cranes Mill to see if she could still incorporate some of their daily routine activities while we did our carnival, just so that they didn't feel too much out of place. But then one of the things that the residents did love about our activities was it allowed them to reflect back on some of their favorite memories, such as eating the cotton candy. That was one of the big things that we did get when they came for snacks. They kept saying like, oh, we haven't had cotton candy in forever, and like how much they enjoyed it. So we were able to at least help with that. And then, yeah.
Okay, so Professor Yuli has a question.
You guys are used to me by now, right? So why 12th grade level for the literacy? Because that's a high level. Even for research, the informed consents are at an 8th grade level. Was there any rationale for that?
Oh, the reason why I said 12th grade level was because most of the residents there, they were college educated. There was a lady who she taught at Caldwell. So it was really easy for them to understand really big words. So that's why I chose 12th grade level.
All right, thank you.
Does anybody else have questions for them? No? All right, great job.
my God.
All right, so we're going to take a break for about 15 minutes, get up, stretch, and then we'll finish up with the rest of the presentations, okay? All right, everybody. So we're going to start again. Is there people in the hallway? Amy, can you grab the people that are out there and just tell them we're going to start?
Who's the technical?
Huh? You just put it in?
We have to put in who has the references of the other presentation?
Yeah.
Where's our representation? Don't even put it aside. Yeah.
Don't even put everything on.
Let's get rid of this. And then you guys are not that one. To Heard, right?
Yes.
I know, but she has held a lab.
Oh.
Right now.
I saw
she would
her.
try to come to
I
see
saw
you.
her for like a minute.
Yeah.
Can
We
we?
should.
Yeah.
Absolutely. She would love that.
It doesn't matter. We can go.
With Dean, Christine in charge, and then we'll all introduce ourselves in the spirit of Dr.
Do it in like
Ryan.
an order.
So we'll go in order.
So go from like one, just pick a direction.
We'll start with you, and then we'll go to Lydiana and go that way.
Do we like come up to the mic or do we just stay?
I think you can hear you if you just introduce yourself.
Okay.
And then it's like, we'll
Louder.
just switch when it's your turn.
Absolutely.
What?
No. 100% professionalism. We'll get going.
I'm gonna stand up.
Is it starting? No, wait, now you're ready. I don't know. Do you think you can hear it?
It should be.
Okay, okay.
My instinct is my 9 minutes. I'm dead.
I don't know what to do. You know what's crazy though? I never would have expected myself to be here. I'm so sorry.
We have a picture, we have a slide with it. We thought that would be most appropriate. Yeah.
Is this it?
I'm not the bad till the light turns on. And I'm like,
Don't jump out. I'm a definite tachycardic. I can't lie. I'm a little tachycardic.
pulse bounding.
+3 by
Let's just say that right. +3. I'm about to curse.
All right, so now that we're all back, we're going to start. So this is Professor DeHerd's group. They were at Chilton Medical Center. So I'm going to turn it over. You can say it
I
again.
was going to say that. All right, hi everybody. We are Professor DeHerd's group. We were at Chilton Medical Center at a cardiac progressive unit. I'm Christine.
I'm Lydiana.
I'm Kevin.
I'm Junita.
I'm Ashley. I'm Amanda.
And our presentation's on sepsis. Silent but deadly. Sepsis silently lurks, taking lives with stealth and speed, making it crucial to shine light on the silent killer. All right. So sepsis is a life-threatening condition triggered by the body's inflammatory response to bacteria in the blood or any infection in the body. The body's inflammatory response becomes overactive, and septicemia can quickly progress into severe sepsis or septic shock, which impairs multiple organ functions. Early detection of sepsis in the body, like increased temperature, increased heart rate, or low blood pressure, is crucial. At least 1.7 million adults in the US develop septic shock, and nearly 270,000 die as a result of late detection and lack of treatment such as fluids and antibiotics. Why do we choose sepsis? Sepsis, the first reason we chose sepsis is because of its clinical relevance. It's a common condition and a critical healthcare issue requiring timely recognition and appropriate interventions. A big reason why we chose sepsis is because of the relevance in our own clinical experience. I think it's safe to say that majority of us have had at least one patient with sepsis or with a history of septic shock. Another reason is because of the education gap. It is crucial to ensure competency of patients as well as healthcare professionals in regards to sepsis. Lack of knowledge in the signs and symptoms of sepsis means healthcare facility members are unable to detect sepsis and treat accordingly to prevent poor patient outcomes. Patients also have an educational deficit because they don't understand the severity of sepsis and how a simple local infection can become fatal. Our final reason is because of patient safety. Early detection and management of sepsis significantly impact patient outcomes and their safety. The quicker we as healthcare professionals can address a patient who may be on the verge of septic shock, the higher the chance of a positive patient outcome. So I'm just going to quickly introduce our patient. Our patient's initials are NK. He's a 90-year-old male with no known allergies upon admissions. He came in on February 1st with a chief complaint of hematuria. Upon admissions, he had a rectal temperature of 34.7 degrees Celsius, a blood pressure of 69/45, and a heart rate of 83.
Hi. So we chose to use the SBAR format as the optimal communication tool to present our patient's clinical situation to our audience. The situation was a 90-year-old male with a past medical history, which includes bladder cancer, hypertension, COPD. This patient was admitted with gross hematuria and later diagnosed with septic shock secondary to a urinary tract infection. For the background, the patient had a complex past medical history with multiple comorbidities. He presented to the emergency department at Chilton Medical Center with signs of septic hemorrhagic shock, which included hypotension as evidenced by the blood pressure that Christina highlighted earlier, and hypothermia as evidenced by his rectal temperature mentioned by Christine. Upon assessment, the patient's vital signs were found to be indicative of severe hemodynamic instability with significant hypotension and hypothermia. These markers were suggestive of immediate intervention and monitoring. Recommendations made were to monitor and stabilize his vital signs, to provide hemodynamic support via intravenous fluids. Lactated ringers was the solution of choice for fluid resuscitation. Broad spectrum antibiotics, which we will cover in later slides more in-depthly, were administered to target his UTI, and also to closely monitor his cardiac and respiratory functions was a highlight for the team, and to consult appropriately with the interdisciplinary team to lower his lactic acid levels, to educate the patient, and to also educate the family about sepsis. So, who's at risk for sepsis? The risk for sepsis spans across diverse demographics, encompassing vulnerable populations such as elderly clients, our very young clients such as preemies and neonates because of underdeveloped immune processes, young people, those with chronic illnesses, those who may be immunocompromised, patients who are hospitalized, surgical patients, patients with a history of sepsis are more likely to be susceptible to sepsis, patients with wounds or infections, Also, patients with indwelling medical devices, and this is my favorite. Our patient had a nephrostomy drain, and it was found that this device was the source of his infection. So we'd like to take this opportunity to educate our audience on the importance of adhering to their organizational antiseptic protocols and policy, whether it's with a Foley catheter that needs to be done, that needs to be performed Foley care with every shift, whether it's a central line such as a PICC that needs to be CHG wiped, any type of medical line, any type of device, the simplest actions such as hand hygiene, relative to our patient's nephrostomy drain, which we have a slide or not, indicating the nephrostomy drain. Excuse me for that. But there are simple steps that we can take to prevent sepsis, such as hand hygiene, keeping our devices clean, emptying them appropriately. These are all very simple steps that we can do to support our patients in remaining healthy and preventing sepsis. Thank you.
Okay, so this is some of the diagnostic criteria that we use in the hospital system in order to detect our sepsis patients as quickly as possible. So we have something called the Sequential Organ Failure Assessment, also known as the SOFA, and that kind of helps us evaluate the organ dysfunction in these sepsis patients and predict their mortality rate. We also draw labs like blood culture. We have lactate, which is our major biomarker in these patients. We have CBC, chemistry panel, and the liver panel tests, as well as urine and wound culture. We also have imaging as well. So we have chest x-ray that kind of helps us detect if the patient has the infection in their chest, like in pneumonia or emphysema. We also have CT scans of the chest, abdomen, and pelvis. National patient safety goals and interventions are regulated by the Joint Commission and other regulatory boards. We also utilize the third international consensus definitions for sepsis. This is kind of a study group. They give us the recommendations of certain cues to look for in these patients in order to detect sepsis as quickly as possible. We also want to evaluate the source of the infection and assess the severity in order to help us guide their treatment in these patients. And that's what that study group is kind of utilized for.
So here we have some lab values based on admission and on discharge. We have the BUN, the hematocrit, the creatinine, and white blood cells, and lactic acid. So I do want to look at the BUN, the creatinine, white blood cells, and lactic acid and know how high they are. I specifically want to talk about lactic acid because being that lactic acid is supposed to be below 2, they had a lactic acid of 18.9. Upon admission, which is dangerously high. So as we see upon discharge, they do have a lactic acid of 1.6, which is like really good. And based on like what they had upon admission, we weren't expecting that same outcome for discharge. So that's actually pretty important to know. So for medical diagnoses, we have septic shock and acute kidney injury secondary to sepsis. We also have the past medical history, which is hypertension, bladder cancer, COPD, lung disease, and sleep apnea. We also have some medications that they were on. We have vancomycin, ceftriaxone, metoprolol, hydromorphone, and epoetin alpha. So this is the pharmacology of it. So vancomycin is a broad spectrum antibiotic, and we saw that they were on it and that they were given it due to a blood culture being obtained and displaying no bacterial growth present. As we looked into it, we did see a note by the MD suspecting a nephrostomy-related infection, being that they had bilateral nephrostomy tubes. They were also on ceftriaxone for the infection as well. They were also on albumin X, which is alpha-1 proteinase inhibitor and volume expander. This works to, This works to increase the blood pressure because of the shock, because it is systemic vasodilation. We have sodium bicarbonate, which is an alkalinizing agent. They used it for metabolic acidosis. And we have norepinephrine, the Livofed, non-selective adrenergic agonist that stimulates alpha receptors and beta receptors of the heart, used for acute hypotension and shock. And we also have the Solu-Cortef, the corticosteroid. This suppresses the inflammatory and immune response to increase the heart rate, blood pressure, and the glucose levels. This was also used for septic shock.
So we came up with 3 nursing diagnoses. First, we have ineffective tissue perfusion related to vascular collapse, as evidenced by poor hemodynamic status and a low blood pressure of 69/45. Next, we have imbalanced fluid volume related to severe vasodilation, secondary to septic shock, as evidenced by a hypotension level of 69/45. Last, we have impaired gas exchange related to increased metabolic demands and oxygen delivery system interference, as evidenced by tachypnea and increased lactic level of 18.9 and decreased level of consciousness. So for interventions for nursing care, hand hygiene to help reduce cross-contamination and number of microbes present. We want to also identify the source of infection, which in our patient's case was his nephrostomy tubes. You want to monitor vital signs, also dressing changes and wound care sterility. Also, you want to wear appropriate PPE and also warming and cooling blanket and/or cooling blanket to ensure appropriate thermoregulation. Also, in accordance to providers' orders, vascular access and fluid resuscitation, administration of antibiotics, and also vasopressors to increase blood pressure. For psychosocial, you want to assess this patient's coping mechanisms and support systems to help this patient emotionally and also help them express their feelings, anxiety levels, and understanding of his medical situation. Most of the time, fear comes from lack of knowledge. Also, a treatment plan for this patient. And then you want to provide emotional support and reassurance, educate and understand, again, for this patient. Also teach them how to look for signs and symptoms and early intervention, social support, and effective communication to provide safe patient care.
Okay, so these are some of the challenges that these sepsis patients tend to undergo. So for the patient himself, before sepsis, a lot of these patients aren't able to recognize the early signs of sepsis, making the treatment delayed, which could cause more issues moving forward when we're trying to treat these patients. Also, another thing we want to realize is that these patients might have some comorbidities before even getting sepsis. So when they do get sepsis, it might be harder to treat and help these patients. After these patients get sepsis, they might have some organ damage or failure, making the treatment a lot harder as well. They might be weak, and that kind of leads us to have more increased care for them to lead their recovery in the right direction. Some psychosocial issues we want to address is maybe support. Maybe they don't have a support system in these situations, and they're undergoing a lot of stress. You know, sepsis is a very, very stressful situation. Maybe they might have some body image issues, or they don't have effective coping mechanisms as well.
Some interdisciplinary challenges that could be encountered could be a lack of experience on how to monitor all those vital signs and how to treat those patients as well. The workload that nurses sometimes have as well, that they don't have enough time to take care of all the patients. The miscommunication at handoff, and I think this is really important, that handoff is done at the bedside, because sometimes the patient is not involved and the nurse's communication. Also, poor interdisciplinary communication and lack of sources and evidence.
So the patient's family might also have some challenges themselves. Before sepsis, they might not be able to recognize the early signs and symptoms of sepsis in their family member as well. And sometimes we have these misconceptions about sepsis and that only hospitalized patients get it and that it's rare, which is actually false. Anybody could get it. Anybody with an infection can be at risk for sepsis. After sepsis, sometimes they might have a lack of understanding about the disease process. Maybe that could lead to some anxiety that they may have. Some psychosocial issues, they might feel powerless because they can't help their patient at this moment in time and we're trying to treat their sepsis correctly. They might feel anxiety and they might also have some coping mechanism issues as well. Some nursing priorities that we want to address is early recognition of sepsis, which is very, very crucial. Again, we want to look at our biomarker, the lactate level, which was extremely, extremely high in this patient. We want to obtain blood specimens for culture and sensitivity. Some big signs and symptoms that we're looking for in these patients in order to treat them effectively is we want to look for fever, chills, rigors, diaphoresis, flush, pale, mottling skin. Maybe they'll have low BP, delayed capillary refill, weak pulses, dyspnea, malaise, confusion, and decreased urination. The labs in this patient suggested end organ failure because he had hypothermia rather than hyperthermia, which means that he was in a very critical state. For this patient, we had early identification and intervention, which saved his life. He did end up going home and he recovered, and that was good on the hospital's part. We want to establish a vascular access. We want to initiate fluid resuscitation for the doctor's orders. That's mostly lactated ringers, which is 30 ml per kilogram, timely administration of an antibiotic therapy per doctor's orders, and continuous monitoring of his oxygenation status. And all of that together, again, saves his life.
For health promotion and maintenance, we want to promote an early detection. And for that, we want to look for signs and symptoms like flush and warm skin, high body temperature or low body temperature, high respiratory rate, tachycardia. And we had to, we noticed that some medications can mask these signs and symptoms as well. We're going to look for those cognitive also signs. We also want to prevent by practicing good hand hygiene and promoting vaccinations, keeping those cuts and wounds clean, receiving routine medical care for chronic conditions, and seeking medical attention immediately if there's any suspect of an infection. For patient and family teaching, we want to teach these patients in what are those signs and symptoms that I explained before. We want to teach the patient in preventing infections because those patients with chronic conditions are more susceptible to those infections. And we want to keep good hand hygiene, and we want to teach those patients how to do it the right way. We also want to teach the patient on keeping those cuts and wound covered until are healed. We pass around some flyers as well that has all the information, cover all the information for sepsis, and we're going to present a video as well.
Sepsis, formerly called blood poisoning, is usually triggered by a local infection, such as pneumonia in the lungs, an infected wound, or infection of the urinary tract. Should bacteria from the local infection spread or secrete toxic substances into the bloodstream, the immune system may sometimes go into overdrive, causing inflammation throughout the entire body. You get sepsis. This interferes with the blood flow, which leads to a drop in blood pressure, making it difficult for the blood to carry oxygen to the body's major organs. This can lead to failure of organs such as the lungs, the kidneys, or the heart. In the worst cases, the patient dies in a matter of hours. Detecting sepsis early is crucial, so be attentive to symptoms such as fever and chills, breathing difficulties, diarrhea and vomiting, confusion and slurred speech, low blood pressure and elevated heart rate, low urine production. Sepsis can affect anyone. Help us stop sepsis.
What should you do if you think you might have sepsis?
And that's the end of our presentation. Thank you.
Does anybody have any questions for them? No questions? I was going to ask a question.
So I think you guys did a really great job, especially in the beginning, just with your presentation skills and bringing us in. I really appreciate that. But also, I appreciate the fact that you differentiated the source, right? So you mentioned that it came from the nephrostomy tube, and it wasn't there was no growth in the blood cultures, which is nice, right? Which is probably why he was able to recover, being a 90-something-year-old patient. That's hard to do. I think my only question regarding the nephrostomy tube is, when was it inserted? Did you know? Sometimes you get sepsis based on the insertion, like of when it's inserted, because of the way the spillage of the urine will create bacteria. So I'm just curious if you knew that. Just out of curiosity, I'm critical care nurse, so these are the things that I think about.
We don't know exactly when he had them inserted, but he did come in with bilateral nephrostomy tubes. So he had them the entire time.
So then that could be the way it was cared for at home.
Yes,
then.
and it came from an assisted living
Yeah.
facility.
Okay.
And I think the nephrostomy tubes were also related to his history of bladder cancer.
Okay.
So I think that this was just this patient's baseline.
Gotcha.
Yeah.
Okay, that makes sense. Thank you.
Thanks, Jackie. Does anybody have a question for them? No?
Can we say one more thing?
What kind of unit are you guys on?
Cardiac progressive.
Yep, we're on a cardiac progressive unit at Chilton Medical Center with Professor DeHerd.
What's the ratio of the nurses to
That's
the
a
patient?
great question, actually. So I'm sorry, I'm going to repeat that for the microphone, but we're on a cardiac progressive unit at Chilton Medical Center. Excuse me, my mouth is really dry every time I give a presentation, so you'll have to forgive me. But we're under the supervision of Professor DeHerd, and we really love it there. The ratio, which is to your question, is about 1 nurse to 4 patients. It's a 4-to-1 ratio. And it really allows the nurses to provide an enhanced, I think, level of care to their patients who are very sick. These are heart failure patients, patients that came in with MIs, patients with multiple comorbidities. So it is an elevated level of care. So they do see a lot of, I think you could compare it to a step-down unit with a 4-to-1 ratio. I hope that answers your question.
Is it typical for a nurse to be managing up to 4 patients on pressors? Because that's typically an intervention in the ICU, especially how critical that patient was in end-stage multi-organ failure with such low pressures. So how is it feasible for a nurse outside of the ICU to manage those pressors with 3 other patients?
I think we may have missed to include on our slide that this patient came in, this is his track of his care. This patient came in through the emergency department at Chilton Medical Center. Because of his clinical presentations, he was transferred from the ED directly to critical care, and Professor DeHerd would support me, I think, on this. He spent about 1 week in critical care, and our interaction with this patient was on the step-down cardiac progressive unit. So his vasopressors and all his critical care drugs would have been facilitated at the critical care level. At the progressive care level, they don't push pressors, run pressors. So what we were facilitating, the care that we were giving him on our cardiac progressive unit was fluid resuscitation, cardiac support, and other areas that were not critical. So from our level of care, he was able to be discharged.
Gotcha. Okay, yeah, sorry, I was just confused. I thought that the pressors were being.
No, that's a
administered on
great
that
question.
unit.
I'm sorry that we didn't
No.
indicate that on our slides.
Thank you. Great job.
Any other questions for them? No. Good job.
The lights will go off.
Okay. Wait, are we, like, you're good doing the clicker? No. Or should I do it while I'm talking?
I think do it while you're talking, and then if we notice like any laps.
Okay, so then I'll just, when I finish talking, I'll just move it, and then, like, I can just do it on here. And then,
Yeah.
like, if there's something, like, you can just, like.
You're a laser
We'll be
pointer?
fine.
Like
No, that's not.
Sorry.
I'm not lazy.
I was just curious.
Yeah, we're good. I don't think this is on, though. I don't think that's on.
I think we just need to like speak into it.
Okay. Hi, everyone. So we were at Cranes Mill this semester, and we are Dr. Burns's group. And the title of our presentation is Memory Lane Diner. So just a little bit about Cranes Mill. It's located in West Caldwell, New Jersey, and they supply the following services. So memory support, independent and assisted living, as well as skilled nursing. They also supply additional services such as assistance with medication management, weekly housekeeping, and personal services such as laundry and meal services. They also offer life enrichment activities that are social, spiritual, physical, and cultural. And for this semester, we were specifically on the memory care unit. So our patients had the diagnosis of dementia. We had 10 residents, 1 male and 9 females, ranging in age from 73 to 95.
Our community Cranes Mill are part of Lutheran Social Ministries of New Jersey. Since 1904, Lutheran Social Ministries of New Jersey has been reaching out in love and service to those in the state who are in need of compassionate care and support. Their mission states, through the power of the Holy Spirit and in response to God's love as revealed in the gospel, the mission of Lutheran Social Ministries of New Jersey is to serve those who hurt, who are in need, and who have limited choices. They've been responding to the ever-changing needs of New Jersey residents. Lutheran Social Ministries of New Jersey provides a broad range of programs and services They also partners with individuals, corporations, and congregations through volunteer activities. They give in kind and financial contributions to also continue to aid those who are hurt and who are in need and who have limited choices.
Okay, so dementia is an umbrella term for the loss of memory and other thinking abilities. So the signs that we can see can greatly vary, but they are progressive. And these include, short-term memory loss, such as losing track of belongings, paying bills, planning or preparing meals, remembering appointments, or maybe issues with traveling outside the neighborhood. And there are different types of dementia, and this can vary depending on the neural damage in the region of the brain. But there is no specific diagnostic test, but we will have doctors who will assess the memory loss and the ability for the patient to perform their ADLs. And treatment is based on cause, but there is no cure. So for treatments, we have either pharmacologic or cognitive stimulation therapy. So for pharm treatments, again, the drugs will not cure, but they will be more of a symptomatic treatment. So we can see psychotropic drugs or cholinesterase inhibitors, and this can improve symptoms with these patients. Or with cognitive stim therapy, kind of similar to our project, it's evidence-based intervention. It's beneficial for mild to moderate stages of dementia, and this can include reminiscence therapy, reality orientation, social and sensory motor activities, and this can improve the patient's quality of life and cognitive function just through the stimulation.
So our project was the Cranes Mill Memory Lane Diner. The purpose and aim was to increase their cognitive abilities by stimulating them through interacting with them and doing reminiscent therapy. We wanted to create an activity where we asked them questions and they were stimulated about remembering things from their past. We wanted to identify effects of cognitive stimulation therapy on their mood and affect in patients with dementia through these activities. As you can see in the photos, this was all around the memory support unit. So it was different settings like post office, like music. It made them remember it when they were outside of the unit. So assessment of the unit and population. The overall socioeconomic status of Cranes Mill is very affluent. The residents are college educated and they had good occupations prior to retirement. Prior to their dementia diagnosis, they were definitely proficient in both written and spoken English, but since of their advanced stages of dementia, they definitely are declining cognitively and with their ability to write and speak clearly.
So this method was originally developed at a senior living community in California, the San Francisco campus for Jewish living, which was also another large-scale facility that included memory care as well as skilled nursing, rehab, and assisted living. And the researchers used multisensory enrichment to individuals in later stages of dementia. And they called these the memory care experience stations. So they were large and immersive platforms designed to engage residents with sight, sound, scent, and taste through various themed experiences, including driving a car, cooking in the kitchen, and walking in the park. There was a positive response from the residents based off of these researchers' assessments. So it included decreased anxiety, less wandering, less depression among the residents, and also while helping them achieve their best function. And the leading researcher was Maria Moretti. This was conducted in 2022. And then to develop this immersive diner experience for the residents, we also collected boxes and containers of familiar food brands, along with creating picturesque menus. And this will help with to provide sensory input, which will aid in their recognition for the residents. And for evaluation purposes, we used a quantitative Likert scale and qualitative questionnaire to evaluate their level of engagement, mood, interest, and program feedback, which will be discussed later in our results. Okay, so this is just like an example of like the setup that we had. This was the table that we had set up for them for the diner, as well as the snacks that we provided them with. Okay, so the intervention identified based on the public health nursing intervention wheel was community organizing. So this first involves selecting a common problem as well as a goal, and based off of our population, the common problem was cognitive decline, as well as the associated behavior concerns that come with dementia prognosis. And our goal was to promote quality of life as well as cognitive protection. And this also aligns with one of the goals identified in Healthy People 2030, which is to improve the health and quality of life for people with dementia, including Alzheimer's disease. And after identifying the common problem as well as the goal, we collaborated with the staff, as well as using the previously stated resources to develop the Memory Lane Diner.
So for our implementation, we started our project April 4th at 10 a.m. because that's usually around their snack time. So it's part of their daily routine. So we're not straying too far away from what their normal is. We did have to kind of steer away from our original plan because Cranes Mill does have a beautiful kitchen setup that we would love to use as the diner scenery. But unfortunately, there was a flood. But as you know, as nurses, we got to think fast on our feet. We just moved into their recreational area and like dining area to continue our project. So our team members' roles included note-taking, evaluation, and food service, like who was going to be like waiters and waitresses, as well as that we included name tags on each of the participants just so we know who we're talking to and able to interact more with them in a more personal level, as well as seating and serving. And our menu consisted of lemonade, iced tea, lactose-free muffins because some of our patients were intolerant to lactose, as well as applesauce in case, just to give them more options rather than the muffins if they didn't want. And our team members engaged patients in social conversations to stimulate reminiscence. So this included who did you go to the diner with, what kind of music did you play when you were at the diner, and what was your favorite order to eat there. And then other team members observed their patients to collect quantitative data that included later in our project.
We developed our evaluation tools based on research and assessment of the population. One of our evaluation tools were a Likert scale, where while engaging with the patients, we would check off how engaged they were, check off adjectives to describe their mood, and at the end, we would ask them if they would like to visit the diner again. And for qualitative data, while engaging in conversations with them, we would ask them questions like what was their favorite order, who they like to go to the diner with, what kind of music they like to listen to promote reminiscence. For our results,
The laptop died. The laptop died.
great. Let's improvise. Oh, it's so, okay. Okay. I got it. For our results, the level of engagement rated 57% of the residents were engaged on level 3, which is the most. 28.6% were engaged kind of in the midway at level 2, and 14.3 were very little to no engagement.
Did you hear? Okay, did you change the slide?
Yeah, I did. Sorry, guys. So rating the mood, we had 6 out of the 7 that were actually interested in participating in as a whole in the diner. 5 out of 7 were calm and talkative. So with the interest, we kind of mean more of like continuously ordering the food, continuously asking questions, answering our questions, engaging with us, things like that. Calm and talkative 5 out of 7. So what we mean by that is while they were there Some of them may have been participative, and then some of them kind of got tired throughout the session. So, but they were still very calm and still wanted to participate. And then there was only 1 out of 7 that was just a little overstimulated. So he had left a little bit early, but overall, while he was there, he did say that he enjoyed what he was eating. So the results for our project was that all patients were able to remember details about their time at the diner, whether it was what their favorite thing was to order or who they loved to go with. So they did like to reminisce about that and the conversations. So some would talk about who they went with, some talked about what they would wear, some residents talked about having like a curfew. So like things were different back when they went to the diner. So if they went when they were like teenagers and they remember like, oh, my mother had a curfew for me and I had to go home. This was all stuff that we really wanted to bring out from them, because it again was stimulating their mind to when they were happy at the diner. So yeah, and a lot of them did like to talk about the music. Again, these were all things that we wanted to trigger for them, that we wanted to bring out as a memory, because the happy did bring out a happy conversation, which is great, because sometimes that's what they need, the little stimulation and happiness. So we were happy to do that with them, and a lot of them were great. So.
So for the evaluation, we were able to adequately work with Rachel Teixeira, who's the director of nursing there, and also Antoinette, which is an RN also and a nursing assistant. The project aimed to assess effects of cognitive stimulation therapy on dementia patients on their mood and affect. We implemented cognitive stimulation therapy through social and reminiscing activities in the diner-themed environment at Cranes Mill. We utilized evidence-based practices to create qualitative and quantitative evaluation methods. The evaluation showed positive engagement levels and improved mood among participants. Patients were able to recall memories and engage in social interactions. The results highlight potential benefits of cognitive stimulation therapy and social interaction for dementia patients by enhancing their quality of life. The findings align with the goals outlined in Healthy People 2030. And this suggests that further research and interventions in similar theme environments to improve dementia care and support can be implemented.
Thanks. That's it. Yeah.
Does anybody have any questions for them?
Hi. Oh. How did you guys, because we were at Cranes Mill as well, how did you feel interacting with the memory unit? Was it difficult? I know you expanded a little bit, but individually, was it difficult with more patients than others to deal on the memory unit?
It was definitely a challenge on the memory unit, just because like the stage of dementia the patients have, like some of them like communicated much more than others. So yeah, it was definitely a challenge. That's why we wanted to use the scale that we did, because it made it a little easier to like engage, not engage. How it was more clear cut for us.
Janine was gonna add something really quick.
Sorry. I just want to also add, it was a little difficult because in that, what we did in our process of like the diner event, thankfully we had a great turnout that day, but even other times when we were there and we were trying to like almost initiate the idea or just, kind of follow in the same practices of asking them past questions, the people on the unit sometimes, and just with Alzheimer's in general, there's mood swings. So you kind of have to adjust accordingly to how you see the emotion see fit, if that makes sense. Like some may be happy one day and then some may be having an off day. So you kind of just have to adjust and go with what you evaluate and what you assess based on that day. And you don't want to like further agitate them if they were agitated. That wasn't our goal. So that's like also a main point. It wasn't so much difficult, it was just more adjusting, if that makes sense.
Thank you. Does anybody else have any questions? Great job. Apologies for our technical issue, but we're good to go now.
Use the clicker.
Can we just, can we just do it on the laptop? We don't have to use it.
Okay.
Yeah, it's working.
Hi, I'm Mia.
Hi, I'm Nicole.
I'm Chris Moore.
I'm Joel.
And I'm Amy. Our project is on spina bifida, and the unit that we're on is 5 West at Shilton Medical Center. And our unit consists of some neuro patients, some cardiac patients. It has telemetry, and it's also a step-down ICU unit.
Okay, for our introduction, we chose this patient because after meeting with the patient, we felt that his story needed to be told as he wants to make an impact on other people, as he has been doing through his social media and brands that he has created. The patient had this energy and passion to share his story with whoever would listen, to help them embrace life and take everything in and appreciate the small things, like, as he would say, like just feeling the rain or spending time with your family. He was very much about having a good mindset because he believes that he could be sulking and complaining about his struggles, or he can enjoy the time he has left. As he said, he's here for a good time and not a long time. Besides the enthusiasm of the patient to participate in being our topic to discuss, spinal bifida is not commonly seen anymore because it can be detected and treated during pregnancy. However, since he was born during a time where technology was not so advanced and mothers did not have to go to schedule ultrasound appointments like nowadays, it went undetected. So this was a very interesting topic to talk about, and it helps the patient spread more awareness about his cause. And then also on the slide, this is just a picture of a tuft of hair, or in his case, he had a sacral dimple, which is what led them to diagnose him. And it can oftentimes be seen on patients that have spinal bifida as a sign, but it requires further spinal tests. Okay. Our patient is TM, 37 male. He was admitted on 3/14/24. Patient came into the ED presenting with symptoms of fever, cloudy, malodorous urine, lethargy, no appetite, vomiting, generalized weakness, pain in abdominal upper left quadrant, non-radiating, and chills and sweats during night. His background is patient has neurogenic bladder and self-catheterizes daily every 4 hours, secondary to spinal bifida, lumbosacral spine, status post L2, L3 laminectomy with resection of a dermoid cyst in 2021 and left leg amputation in 2021. Patient first noticed symptoms 6 days ago, and he took a prescription of doxycycline that he had in his home for 1 day, but then as the symptoms progressed, he discontinued the same day. When patient came to the hospital, he had presence of E. coli and urine that traveled up to his kidneys. Upon our assessment, which was 3/21, which was 7 days post-admission, he was awake and alert, rested comfortably in bed, perla, regular rate and rhythm, diminished breath sounds in the right lower lobes with crackles, normal active bowel sounds, soft, non-tender, no visible rashes, no deficits noted, and right leg numbness, weakness, and muscle atrophy, left leg below the knee amputation. For extremities, no edema in lower extremities, and recommendation is repeat blood work of white blood cells, BUN, creatinine, antibiotics, and education. For the patho of spinal bifida / tethered cord syndrome, it is also known as split spine. It is a neuro tube defect that results in the vertebrae failure to close. Possible defects include anencephaly, encephalocele, meningocele, and myomeningocele, and spinal bifida occulta. In some cases, when there is no visible exposure of the tissue, the term spinal bifida occulta is used. This type causes no neurological dysfunction as there is no spinal cord and nerves damaged. However, it can present itself as a sacral dimple
on a newborn infant. Tethered cord syndrome developed after surgical implementations have been performed for correction of the myomeningocele, which is a sac-like cyst containing of meninges and spinal fluid. In tethered cord syndrome, the cord becomes abnormally attached or tethered as a result of scar tissue. His official diagnosis, which was related to his spinal bifida, was septic shock secondary to UTI with E. coli with pyelonephritis. When he was first admitted, his white blood cell count was about 15,000, and when we saw him, it was trending in the right direction, around 9,000. And also, upon admission, his initial urinalysis was cloudy, moderate blood in urine. He had orange urine. There was traces of glucose, large leukocytes, and traces of protein. His discharge medications was bacitracin, which was topical use, bisacodyl, Cifro, Colase, oxybutynin, tramadol, and trazodone. And also the Cifro was PO being discharged with. His nursing diagnoses that we came up with were impaired urinary elimination related to neurogenic bladder from spinal bifida, as evidenced by chronic urinary retention and dependence on self-catheterization. Knowledge deficit, his second nursing diagnosis is knowledge deficit on health management related to lack of compliance, as evidenced by waiting too long to self-catheterize, his inappropriate technique, and misuse of antibiotics.
Okay, so for some nursing care, we have psychological and psychosocial integrity. So starting off with psychological integrity, we have basic care and comfort. So some nursing care and management for TM included preventing infections. An example would be frequent hand hygiene and appropriate use of antibiotics. Pain management, so the same thing, use of proper medication to treat pain. Maintaining skin integrity, so preventing complications such as pressure ulcers and skin breakdown by frequent repositioning and regular skin inspections. We have increasing coping skills, so empowering TM to effectively manage challenges related to his condition to maximize overall well-being. And support system, which included his wife and family members to help TM navigate the physical, emotional, and practical challenges associated with his condition. And then we have some of the medications that TM was on in the hospital, starting off with Rocephin, which was the first-line antibiotic used to treat TM severe E. coli infection. Heparin was used to prevent clots. We have lidocaine topical, which was used to relieve neuropathic pain topically. We have Tylenol, PRN, that was used for mild to moderate pain as needed. And then Tramadol, which is an opioid, so it was just a stronger pain relief that was also used as needed. And then for psychosocial integrity, so providing psychosocial care is crucial in addressing TM's emotional, social, and psychological well-being. So providing comprehensive education. So luckily, TM was very knowledgeable about his condition and had a very positive attitude and outlook towards his treatment, offering ongoing support. So TM had tremendous support from his wife, his family, and all his friends. So he stated that he loved educating people about his condition, and he openly speaks about his condition on social media, where he has a very large following. There, he's able to connect with others and receive support from his online followers who are fascinated and inspired by his story. He also opened up his own vitamin shop. He has a bodybuilding company on the side, and he just started up a podcast/clothing brand that he sells merch for his podcasts, where he's able to speak to listeners who suffer from anxiety and severe depression, because even though he does have a positive outlook towards his condition, he did struggle with mental health. So now he wants his followers and listeners to have a platform that they can refer to. Fostering independence, so just ensuring that TM is able to perform his ADLs appropriately and independently. And then addressing body image and self-esteem. So TM had a left leg amputation and now has right calf muscle atrophy. So just using a patient-centered approach to enhance quality of life. TM also showed frustration towards erectile dysfunction treatments such as pills like Viagra and other penile injections in order to have sexual intercourse with his wife. And he stated that that was impacting his marriage. At the time spoken with TM, he stated about his upcoming plan to have penile prosthesis surgery. And now current day, I want to say about 2 weeks ago, he did follow through with that and everything was successful. So therefore, just acknowledging the emotional and psychological impacts brought onto TM is crucial.
So for nursing challenges, interdisciplinary involvement, spina bifida is a complex condition that requires interdisciplinary involvement from various healthcare professionals to address its multifaceted needs comprehensively. During the client's stay at the hospital, he was treated, consulted, and attended by his care team that includes the hospitalist, neurologist, physiatrist, urologist, physical therapist, occupational therapist, respiratory therapist, case manager, nurses, and the unlicensed assisted personnel, which I also wanted to mention because all, people in the healthcare team matter. And I think that it's really great to incorporate all these team members. So for patient challenges, the patient did have challenges with depression, anxiety, suicide ideologies, mobility, neuropathy, extensive spinal repair surgeries, sexual dysfunction, and pain. TM has several challenges in caring for himself and the involvement of his family. He has reported feelings of depression, anxiety, and suicide. He has mobility issues due to having one leg amputated. While having neurogenic bladder, TM has to self-catheterize daily and has difficulty with having hygienic accessibility at all times, putting him at risk for infection. Due to having spina bifida, TM experiences sexual dysfunction while being married. He has tried different methods in an attempt to have a normal lifestyle. TM's wife has stood by his side through many hardships, including 13 spinal surgeries and the leg amputation surgery. She verbalized her admiration for her husband, although she expressed her concern of all the pain and suffering he was in and how he can be alleviated. Family challenges that TM had with his family. So his mother, she didn't attend doctor's appointments while pregnant. She didn't go to ultrasound appointments while pregnant. There was a lack of adherence to prenatal vitamin regimen while pregnant. She did, have substance abuse issues like cigarettes and alcohol while pregnant. And then lack of coitus with husband due to, for his wife, the lack of, sexual intercourse with husband due to sexual dysfunction. And then the financial challenges of the husband's intensive care, medical needs. So additionally, TM also mentions the challenges his mother faced while she was pregnant with him. Like I said, she didn't attend the doctor's appointments, ultrasounds, or take the prenatal vitamins. She smoked cigarettes, drank alcohol, and was a partier throughout her entire pregnancy, living in rural Scotland during that time. So I know Nicole mentioned before that, during the time that he was born, there wasn't a lot of technology available. I just wanted to clarify that he was born in rural Scotland, in an area and in a country where, those resources may not have been readily available. TM does advocate for his mother and puts no blame on her because of the lack of knowledge and education she had, not knowing the consequences of her actions.
Okay, so for nursing solutions, we have outcomes and benefits with evidence-based practices. So the solutions that were used by the bedside nurses and client outcomes, things that they could do or did: monitor color, consistency, and smell of urine. It's a basic indicator of urinary tract function. looking for abnormal findings such as hematuria, which could indicate kidney dysfunction, foul smell, cloudy color, they could be a sign of infection. It's important to report these immediately to the medical team. The next thing is to monitor BUN and creatinine as indicators of kidney function. This ensures adequate measures are taken to protect and restore proper kidney function. Creatinine is one of the most important indicators in conjunction with BUN. And then to also monitor for any acute kidney injury, which causes scarring and dysfunction and can cause further issues down the road. The other is monitoring for vital signs, indicating infection due to sepsis, communicating the findings to the medical team with the goal of limiting patient complications. It's important to report that immediately, and the client was already in a very fragile state when he came in. And of course, the sepsis, as we've talked about and other groups have covered, it's a serious condition causing tissue damage and even death. Another solution that the nurses used were mutually agreed upon pain goals, and this was put in place to promote effective communication and enhance patient comfort. And it's also important to just keep everyone on the same page. The last solution that we have is to provide perennial catheter care, reducing the risk for CAUTIs or catheter-acquired UTIs. These have negative consequences on the patients, increases their length of stay, increase healthcare costs, and can lead to negative patient outcome. For evidence-based practice, one of the studies that we found by Zhang et al. Mentioned the following EVPs for patients with spina bifida. And that would be for the first, use of clean technique in intermittent catheterization. It prevents urinary retention, reduces risks of infection. The next would be discussing bowel training regimen as part of intermittent catheterization. And this would help to establish control over the patient's urination and further independence. The next would be utilizing pharmacologic measures to reduce bladder constriction. These help promote bladder relaxation and reduce bladder pressure to avoid urine backing up into the kidneys. The last would be addressing psychological needs of the patient with regards to compliance and elimination. This helps to ensure compliance and independence.
So for health promotion and maintenance, health promotion and teachings at discharge with the patient, antibiotic use, we want to make sure that he gets a proper prescription and take the whole prescription. That should make sure the infection is out of the system, and not taking the whole prescription can lead to antibiotic resistance or superinfection. We also want to make sure that he hydrates, drinks a lot of fluids, around 2 to 3 liters a day, which helps flush out the bacteria of his bladder, and then to also monitor intake and output. For catheterization, we want to make sure that he's properly hand washing at home, to use a small lumen and good lubrication of the catheter to prevent ureteral trauma, and then to have him be on a regular schedule for bladder emptying. Want him to catheterize every 3 to 4 hours and no more than 6 hours at maximum. And then for infection, we want to teach him the signs and symptoms of infections, such as fever, chills, tachycardia, flank or back pain, foul smelling, cloudy urine. And then if he shows these signs to refer to the PCP. And then for mobility, mobility was a big thing for him as a bodybuilder. We want him to resume his activities of daily living And by moving around, it can bring his mental state up and to at first to take it slow while he's still recovering and then progress. And then National Patient Safety Goals. It was a program established by the Joint Commission, and it helps accredited organizations to address specific areas of concern in regards of patient safety. And then for the hospital chapter, we identified 5 goals. Identify patient correctly, use at least 2 ways to identify patients, improve staff communication, get important test results to the right staff person in time, use medicine safely, record and pass along correct information about the patient's medicine, prevent infection, make sure that we are hand washing and ensure that we have a clean environment, and improve healthcare equity. And then each year, approximately 1,427 babies are born with spina bifida. And then, thank you. Oh, he consented to this picture? Oh my God. Okay.
Does anybody have any questions? We're all questioned out.
Yes.
Well, I guess you guys are off the hook then. Good job.
Oh, you did it.
Good, okay. Good morning. We did a diabetics education fair at Essex County Hospital Center. That was the site where we were. This is a long-term facility. Is this changed? Changed it. Got it. So this is a long-term facility for psychiatric patients, specifically for schizophrenic patients. So our population consisted of every patient that had diabetes, that was a pre-diabetic, and that was a risk for developing diabetes. So our objective with the fair was to increase their knowledge about diabetes and the potential complications that they could have. We chose this population specifically. I mean, was everybody was schizophrenic, but we chose education on diabetes because everybody is on antipsychotics, most of them, specifically atypical antipsychotics in schizophrenic patients. They're at risk for diabetes, so that was like the focus of our project.
And so for our goal, we wanted 70% of participants to be able to at least select one potential complication of diabetes, one symptom of hypo and hyperglycemia, one diabetic foot care principle, and selecting 2 healthy food choices.
So background, the main intervention was health teaching in a community-focused setting. And we targeted adults with diabetes as well as anybody with prediabetes. Since Valeria said they are all at risk. Some of the challenges that we faced, we spoke to Ms. Lutter, who is a nurse at the facility. And originally our plan was to create a sort of mock supermarket. So beyond hospitalization, they would be able to go out. Some of the patients have been there for as long as, I don't know, 10 years, some even more than that. So think about it, it's 2024, just 4 years ago was COVID. Times have really changed in the last 4 years, in the last year. So a lot of them don't know how to go to supermarkets. So that was our plan originally. But after speaking with Ms. Lutter, we found out that after they are discharged from the facility, they get limited money and they're placed in boarding homes with no refrigerator, no kitchen, and I think like $20 a week, she said, which to us, that's not much. And to them, that's not much either. And so we realized that this idea was not realistic. And we altered the plan to ensure a community-centered focus was attained and then more focused on the diabetic teaching so they can choose those foods post-discharge by themselves and be able to maintain a good diet as well as just maintaining their diabetes in all other aspects.
So this was the first station that we had at our health fair, and it was just a general overview on what diabetes is. We educated patients as well as staff on how diabetes affects the body, as well as talking about the differences between type 1 and type 2 and how each is managed. We also educated our participants on how certain antipsychotic medications can increase your risk of developing diabetes. So this made it a very relevant topic for our community.
So this is an example of one of the handouts that we gave for the first station. We definitely wanted to curate it to their educational level. So there were staff members present too. So we kind of had to change the way we were explaining things with bigger words and smaller words to curate it to the type of person we were talking to. And this just highlights the differences in the treatment regimens for type 1 and type 2 diabetes. And then to evaluate the effectiveness of the first station, our goal was for 70% of participants to answer 3 out of 4 questions correctly. So we have this quiz that you can see on the right, and they're just true and false questions. So after Brianna and I explained our station, they were offered this quiz. And I mean, some of them we had to help, but most of them did it all on their own. So we had 19 total participants, and out of these 19 people, 18 answered at least 3 out of 4 questions correctly, which was a 95% success rate.
So station 2 is all about hyper and hypoglycemia, and patients were taught in very simple terms what the signs and symptoms of high and low blood sugar. And we displayed it via illustrations on these boards. We color coordinated it, and really in simplest terms, recognizing those signs. They were evaluated with these boxes, which we'll get into in the next slide, but kind of identifying which symptoms belong in each category.
So like Bridget said, we had their cognitive level in mind. We tried to be as clear and as straightforward as we could. So with hypo and hyperglycemia, we made emphasis in, high and low and things very specific to it, like hypoglycemia, the shaking, the tachycardia, rapid, heart rate. With the hyperglycemia, that you can go into diabetic ketoacidosis, just very specific points. So we wanted them to be engaged and not overwhelmed. We did those little boxes right here. They were basically like a matching game. So we had 3 symptoms for each. Those were the same exact ones that we mentioned, minutes before they took the little test. We also offered help if they needed it, but most of them were able to get it. For our evaluation, we were looking for 4 out of 6, and most of them got it. And we had an average of 90% correct. They didn't really need any help, and they seemed to be very engaged.
So the third station was based on foot care management. Oftentimes, foot care management with diabetes management is very overlooked. Many people with diabetes often prioritize their nutrition and their diet and their diabetes management with their insulin and stuff. So the pathophysiology of diabetes, and the skin integrity was often something that was in their last of their minds. Thankfully, we did have, while in our collaborations, we did have a staff member who was kind enough to share that her father was actually someone who was struggling with the complications of poor foot care. So after she shared that, we thought it was very, very important to implement this also into the diabetes education. We presented with them first with a very general and basic understanding of diabetes and how it does affect the feet. So we shared that over time, the high levels of blood sugar damages the blood vessels and affects the perfusion, affects the healing impairment, impairs the healing, and it affects the nerves. So it leads to neuropathy, feelings of tingling and numbness. So after that, we established what are some signs and some skin disintegrity or signs that their feet would be a concern in some pictures that you can see below. We share several pictures of the stages of the complications. Obviously, the last would be very bad and it can lead to amputation. We shared that with them as well. We shared them with the pictures of the concerns such as corns, very dried skin, cracked skin, cuts, calluses, etc. And lastly, we would evaluate their learning through a foot care quiz. So in terms of how they would maintain their foot care, we told them that they should wash their feet daily, emphasis on daily, not every week, or not every 2 days, but daily. And we told them that they should pat dry their feet with a towel, especially not to air dry, because we know that bacteria and fungus likes to harbor in wet environments. So we want to make sure that they're patting it very dry, especially in between the toes. We would tell them to inspect for bumps and spots of tenderness in their feet if they're feeling for it. And if they have any troubles looking at their feet, we encourage them to use a mirror or to even ask for guidance of the nurse to assess for them. We also told them not to walk barefoot because they can still risk injuring their feet in the indoors as well. And of course, we told them that we encourage them to see a podiatrist to make sure that the nails are cut and any abnormalities are checked.
So to evaluate our station, we created a mini diabetic foot care quiz. It was composed of 6 true or false statements. And the statements read, number 1, people with diabetes should inspect their feet daily. Number 2, it is safe for individuals with diabetes to walk barefoot, even indoors. Number 3, cutting toenails straight across is recommended for individuals with diabetes. Number 4, people with diabetes should allow their feet to air dry after showering. Number 5, regularly checking the bottoms of the feet for any minor foot injuries, such as blisters or cuts, is important. And lastly, number 6, regular podiatrist visits are important for people with diabetes. So the majority of our participants were able to answer these questions on their own. There were a few that needed help. And so the goal was at least 80% of the participants will answer 5 out of 6 questions correctly. We had a total of 46 participants, and 20 participated at our station, with all of them that took the quiz, and 100% correctly scored at least 5 out of 6 questions. The outcome exceeded our goals and expectations. The participants were very engaged with us in our station as well.
Okay, so Julia and I were in charge of Station 4, which was all about nutrition. We utilized something called the diabetes plate method. So if you're not familiar with what this is, it's a visual representation of a plate divided into 3 different sections.
And so participants were kind of asked to help assemble a plate to see if they could create a properly portioned diabetic meal. So half of the plate should be non-starchy vegetables, 1/4 of the plate should be lean protein foods, and 1/4 of the plate being your carbohydrates. And we kind of stress more on choosing healthier carbs just because carbs have the greatest effect on sugar levels. And these were kind of some of the examples we went over of acceptable foods. So we kind of showed them what are non-starchy vegetables, what are lean proteins, what are carbs, and kind of what are good drink options for diabetics. Water, of course, being the best option.
And then the evaluation. So they were given 2 choices for each food category and asked to select the proper portion option. So for the non-starchy vegetables, they had a choice between broccoli and a baked potato. For carbs, they had brown rice or cupcake. And for proteins, they had grilled chicken or fried chicken. The goal was that 70% of these participants will successfully create a portion plate. And 17 out of the 19 participants that attended our table correctly assembled this diabetic plate. So that's an 89% success rate. 93.5% success rate average between all of the stations. Multiple participants voiced that they were prepared regarding diabetic management post-education, and staff members really enjoyed and appreciated us allowing the patients the opportunity to come off the unit for education, as well as socialization, because we also realized that that was a problem within the facility. And some direct quotes from patients. Thank you so much. This was so informative. I didn't know all of this before. You guys are so good. I learned new things just from being here. I didn't know about all of these foods that I can eat. Now I know what to tell my parents to bring me. Thank you for putting this on. The patients loved it. They also enjoy having new faces to talk to. And thank you to Dr. Anderson. To show our appreciation to the staff and patients, all participants were given a snack prior to their departure. So thank you, Dr. Anderson, for all your help in planning our education fair and setting that up for us as well. Thank you.
Does anybody have any questions for this group?
Being that our group kind of touched on diabetes, I really like this presentation. It really showed a lot of interventions, and this is how we can prevent people coming in the hospitals, you know, with diabetes, because it's really preventable and it really can be controlled by dieting. So I really appreciated this presentation. Thank you.
Anybody else have any other questions, comments? After the break groups are getting off easy. All right. Oh, wait. Time out.
I have to congratulate you. I think your project is grant funding worthy. I hope Essex County Hospital takes advantage of what you've brought to their patients. Thank you.
Thank you.
All right, nice job. So I am going to ask a favor after the last presentation, which is coming, if everybody could stay, because we're going to take a picture.
Yay.
I need a memento.
All right, can you guys hear me? Okay. All right. I know we're the last group, so please try to stay awake. So, okay, I know we're all burnt out, but okay. So, hi, I'm Myrna.
I'm Kelly. I'm Manueli. I'm Rashika. I'm Christina.
I'm Presley.
And we are from Morristown Medical Center. We were on Gagnon 1, which is a cardiac telemetry unit. And our instructor is Hazel Magbatang. So this is just a table of contents just to line up what we're each going to talk about.
So we chose scleroderma. And what is that? It is a rare autoimmune disease that causes hardening and tightening of your skin and connective tissue. It typically happens in your hands and feet, but it can go up to your, like throughout your arms and your legs. There's two types. It can be localized or systemic. And why is this important? Because your skin is a very big organ, and scleroderma will affect it throughout your entire life. And then it can also affect, if you have the systemic version, all of your internal organs. So it is very, very serious and it's very rare. So we chose this topic because we wanted to give scleroderma a little bit more of a voice because it is so rare.
So this is a little bit about our patient. Our patient is a 75-year-old male who comes from home with his wife and presented to the ER on February 16, 2024 with a chief complaint of shortness of breath on exertion and a scleroderma flare-up. He also has a history of acute systolic heart failure.
So for our SBAR, for our situation, our patient was admitted on 2/16 with shortness of breath, like Myrna just said, and was also suffering from an acute flare-up of his scleroderma. Other current conditions that he has were systolic heart failure, pleural effusion, and acute kidney injury. Some background about him would be that he had a history of hypertension, stage 2 kidney disease, osteoporosis, coronary artery bypass surgery, pleural cavity thoracentesis, and he stated that his current scleroderma began out of nowhere about a year ago and denies any family history of it. So for our assessment, we noted that he's alert and oriented ×4, PERLA, his pupils were 3 millimeters, he wears glasses, and his speech was within defined limits. For respiratory, he was short of breath on exertion with diminished lung sounds in the bases, which was concerning because of his scleroderma. We want to consistently monitor if it's spreading to the internal organs. For cardiovascular, he had normal S1, S2 sinus rhythm, 2+ radial pulses, 1+ popliteal and pedal pulses. For GI and GU, he was continent in both, had normal active bowel sounds. For musculoskeletal, he had joint stiffness bilaterally, and he used a rolling walker for ambulation with 1 to 2 assists. For his integumentary, his skin was flaky, irritated, dry, pale, tight, and there was a wound on his left ankle and a puncture on the anterior neck. And his latest vital signs were all within normal limits. For his care plan, we want to effectively teach him and his wife that he lives with at home about skincare and the importance of keeping his skin moisturized. We would want him to keep follow-up appointments with a cardiologist, dermatologist, and primary care provider. We want to assist him with ADLs, especially due to his joint stiffness. We want to make sure that the patient is on a heart monitor and monitor his I&Os and educate on optimal nutrition status and weight.
Okay, so we did have a few different nursing diagnoses for him. The first one being impaired skin integrity related to skin fibrosis and decreased tissue perfusion as evidenced by thickening and tightness of the skin. Our second one was activity intolerance related to stiffened joints and weak muscles as evidenced by restricted range of motion. And then our final one was impaired physical mobility related to skin and musculoskeletal changes as evidenced by weakness on exertion. And then on the right side, we do have a few interventions highlighted, but we will go into depth in a little bit.
Okay, so like Kelly said, scleroderma is an autoimmune disease. It's also an inflammation response. So basically, the best way that I could describe it, that the patient described it to us, is like your skin turns into leather. So basically, it's an overproduction of collagen, and your connective tissue turns, it's like fibrosis, like it's fibrotic. So basically, it's actually really painful because your skin is constantly tightening, especially around your hands. It creates all these type of lesions and stuff like that. As for the causes of it, there's not a lot of research done on it. There is a genetic component where it can be hereditary. There's also a lot of environmental factors that can contribute to it, but the most importantly is stress. If there's a huge traumatic event, it could cause the autoimmune disorder to occur. In regards to our patient, he can't think of a specific physical traumatic event that could have happened, but he does think that an emotional, stressful event happening earlier in the month with his wife that had a severe fall that left her bedridden for a couple of months could have caused it. And then just to reiterate again, his medical diagnoses that he received in the hospital were acute systolic heart failure, pleural effusion, and AKI, which is the acute kidney injury. And then on his history, he had a history of hypertension, coronary artery disease, and also stage 2 kidney disease.
So this is a slide of all the medications our patient was on, specifically related to scleroderma, though. He was treated with immunosuppressants and steroids, methotrexate, prednisone. He also was given pain meds because, like Manny mentioned, this condition is very painful because your skin is literally turning to leather, and it's just constantly inflamed and swollen.
So the nursing care through the continuum, basic care and comfort pharmacologic care. Skin care, we want to inspect the skin regularly for changes such as swelling, ulcers, thickenings, lacerations. We want to maintain moisturized skin with a hypoallergenic lotion. We want to apply sunscreen and wear protective cotton clothing in the sun and avoid hot showers, baths, and harsh irritants, and remove anti-embolism stockings for 30 to 60 minutes just to have the skin breathe. For pain management, we want to assess the pain levels regularly and provide care accordingly. Non-pharm things we could do is have him do deep breathing exercises, meditation, distraction, musical therapy, and pharm management would be NSAIDs, steroids, and opioids. For nutrition, we would encourage small, frequent meals for him, increase calories, increase protein intake to promote healing of his wounds and lacerations all over his body. Pharmacologic measures in depth would be immunosuppressants to reduce the progression of the disease, the thickening of the skin, and lung damage. Blood pressure medications to dilate blood it may help with Raynaud's in patients with scleroderma, and steroids such as prednisone to decrease inflammation, and pain medications such as NSAIDs and opioids. Again.
All right, so patients with scleroderma do face a lot of different challenges, one of them being body image issues. And this is because they do have physical skin changes, and it does result in physical limitations as well. So as nurses, you would want to provide information on coping strategies, and maybe give them a support group that they can utilize. We'd also have them engage in activities that promote body positivity and also increase their self-esteem. And then we'd also just want to validate and acknowledge their feelings while we're talking to them. And then at pain management, non-pharmacological, like Rashika said before, we would do distraction techniques, reading, music, meditation, and then we'd also give medication appropriately, so NSAIDs, opioids, depending on his pain level.
So from our patient's point of view, first having this diagnosis, he was very fearful and uncertain of how much of his condition will grow and affect his life. He was lucky to have his wife still alive and living with him who could help him with like activities of daily living. And then he was also very thankful to have a diagnosis to get medication for his inflammation. And then he also was looking forward to PT and being able to maintain his ADLs as much as he could. And then lastly, he just was happy that we chose him and gave a more of like a voice for scleroderma.
For psychosocial integrity, some goals that he had was to maintain his normal ADLs regarding his joint stiffness. He wanted to connect with his family and friends and teach them about his situation so they could be less fearful for him and know that he's going to be okay if he just maintains the treatment. He wants to pursue his hobbies that he enjoys. He told me that he loved watching soccer and he was like a huge soccer fan, so he wanted to be able to play with his grandkids. So he wanted to get as much treatment as possible for that. We want to encourage patient self-expression and educate appropriate coping strategies and support groups.
Okay, so we would want to utilize other people within the healthcare when approaching this patient. We would really like to utilize physical therapy as well as occupational therapy. And this is just basically to help maintain strength and range of motion and just help him keep his independence, especially with his activities of daily living. We'd also want to consult with nutritionists and registered dietitian, again, giving him a proper diet that's high in calorie, high in protein, just to facilitate, healing and keeping his strength up. We'd also utilize a respiratory therapist because often patients with scleroderma can have respiratory problems such as shortness of breath, ineffective coughing, and it can even lead to respiratory failure. So you want to make sure they're performing pulmonary function tests and maintaining adequate ventilation. And then, of course, you want to consult with the wound care nurse because oftentimes they do have open wounds throughout their skin.
So we were able to find an article with research on scleroderma. As I stated before, it is not really researched enough, but they did conduct a study in May 2021 in the Department of Dermatology in the University of Texas Southwestern Medical Center. In the study, they conducted a bunch of clinical trials testing out specific drugs in relation to scleroderma, observational studies, and then also they got reports back from patients in regards to treatments and how it benefited them or not. So 90% of patients who have scleroderma previously had Raynaud's phenomenon. So it's kind of like a precursor, and some basic modifications that can be had is just to avoid smoking and cold exposure. Later on, as the skin disease progresses to actual scleroderma, there's some other medications listed here that they could take. So the first one, methotrexate, that's actually one that our patient's on. It's an immune suppressant since it is an autoimmune disorder. Then there is, excuse my pronunciation, but Saximba, it's basically for his arthritis. And then there's also mycophenolate, that's to help when the disease progresses and it goes to like the organs and stuff like that, it's to help try to reverse that in a sense. And then there is UVA phototherapy, which is just to help with his dexterity and stuff like that. Other symptoms that can also be shown with scleroderma is calcinosis, which is basically a ton of calcium deposits show up, especially on your fingertips, and it's really painful and uncomfortable. So they could give the medication to try to reduce the calcium in their system, or they could have surgery to try to remove that. There's also microstomia, if you see over here, is basically where your skin tightens so much that your mouth becomes small, which makes it very uncomfortable for them to talk, to eat, to take medicines. You can imagine some things that we could do to try to help in that way is trying to do mouth exercises. And then also there's this other word, is basically when you have, is basically when you have your vessels dilated, and usually they show up on their face, and it's like a clear sign that you have scleroderma. On top of that, there's also general skincare. Patients said that the best way to like help is just keep your skin moisturized, to wash with warm water, and to keep fragrance-free moisturizers and limit baths.
So some nursing solutions or approaches that could be used. So first, pain management, PT, exercise, heat and cold therapy, and medication. Skincare would be for people with scleroderma, they will develop thicker, tighter skin, which increases the risk of infections and skin breakdown. Nurses can instruct patients on how to take care of their skin, including how to apply moisturizers and mild cleansers and protective bandages. Physical therapy. For individuals with scleroderma, physical therapy can increase joint strength, flexibility, and mobility. Together with physical therapists, nurses can create safe and efficient personalized exercise regimens for them to adhere to. Occupational therapy. Patients with scleroderma may be able to preserve their independence in everyday activities with the use of occupational therapy. Occupational therapists and nurses can collaborate to create adaptations and assistive technology that can help patients carry out their daily duties. Respiratory care. Breathlessness and other respiratory issues might result from scleroderma impact on the lungs. When necessary, nurses can instruct patients on oxygen therapy, correct breathing practices, and other respiratory therapies. Nutrition. As malnutrition can worsen symptoms, it is crucial for scleroderma patients to follow a healthy diet. In addition to monitoring patients' nutritional status and administering supplements as needed, nurses can educate patients on the importance of eating a well-balanced diet. For monitoring, people with scleroderma may need to have their condition continuously monitored, which may involve routine medical checkups.
Okay, so for health promotion and maintenance, so unfortunately, scleroderma is very inclusive and not in the good way because it can affect many different body systems. So a complication that may arise includes kidney failure, pulmonary fibrosis, which is just a fancy way of saying scarring of the lungs, which you can imagine how hard it must be for the patient to breathe in that scenario. Heart disease, congestive heart failure, and immunodeficiency. Patients with this diagnosis are taught to notify their healthcare provider immediately if any of these signs and symptoms occur: shortness of breath, discoloration, or loss of sensation at the fingertips. So we really want to tell the patients to watch out for this because, as Manny mentioned, Raynaud's phenomenon can become so severe that it can cause necrosis, and it can cause restricted blood flow and permanently damage the tissue and result in necrosis, like I said. Next, a sudden increase in blood pressure, which may indicate a renal crisis, so we want to tell them to report that right away. Next, abnormal heartbeats or palpitations should be reported, as scleroderma can cause scarring of heart tissue as well. And finally, a decreased oxygen saturation. Any random drop should be reported immediately to the healthcare provider. So I decided to throw up the National Patient Safety Goals by the Joint Commission. So that includes identifying patients correctly, improving staff communication, using medications safely, use alarms safely, prevent infection, identify patient safety risks, improve healthcare equity, and prevent mistakes in surgery. So in this case, we want to focus on preventing infection, especially with the open wounds on this patient's arms and legs. So ensuring, adequate hand hygiene and just proper precautions to take to avoid getting an infection. So the Joint Commission puts these in place to promote, optimal patient outcomes and promote just overall safety. So along with ensuring that the NPS goals are met, we also want to educate the patient and family to make sure that they're achieving optimal health. So you're going to want to teach them. You're going to want to teach the family and the patient how to properly perform dressing changes. I suggest using the teach back method, as it is an evidence-based strategy and it's proven to be most effective. You're also going to want to teach signs of infection and when to seek care. Along with that, you want to teach infection prevention and the importance of performing proper hand hygiene prior to dressing changes. And lastly, you want to teach the patient to never discontinue a medication, especially since Kelly mentioned this patient is on prednisone, that's a steroid. And I could just hear Dr. Rhodes' voice in my head saying, taper off the medication, please. So you want to taper off this medication or it may result in an adrenal crisis. You don't want to mess with steroids. I learned the hard way. Okay. So for wound care and management, so we kind of like ran a little skit for you guys. But here in this picture on the left, we gathered some supplies as if we were doing wound care on this patient. So at the top here, we have some gauze sponges, saline, acrylics, gauze bandage roll, scissors or shears, and some paper tape. And then in this middle picture, we have an abdominal pad here on the left, and that's if the wounds are, extremely saturated. You're going to want to use a bigger pad like the abdominal pad. But if there's minimal drainage, you can use the non-adherent Curod pads. So the video doesn't have sound, so I'm just gonna like talk you through it. Okay. Oh no. Okay, so she's opening up the gauze now, and what you're gonna wanna do first is you're gonna wanna clean the patient's, wherever you're gonna do the wound dressing. So she's putting the saline on the hands right now, and then you're gonna wanna pat dry with gauze, making sure that you're getting every piece of the hand. And then you're gonna flip the hand over, clean the other side. And you're gonna pat dry. So yeah, she's really going in here. She's really drying it up, making sure she's getting everything. Okay, now she's gonna take the Curlix and she's gonna start to roll it up against the hand. So she's gonna go around a few times, and you also wanna make sure you're not going too tight because you don't wanna restrict any blood flow. So she's gonna go around and then goes around the thumb too. And then she's gonna cut it right over here. And then this is when your paper tape would come into play. You could secure it with paper tape and then remember to initial it. This was not me, this was Presley. She used my initials though. And then you date it, so. Okay. Escape. All right. Wait, am I back? Oh no. How do you guys present this again? Wait, should we escape one more time? Oh, they were there, okay. All right. And yeah, don't forget to initial and date with your own initials though. Presley. All right.
And here's just some patient monitoring that we should do. So for skin, you should do a daily skin assessment. You should do proper cleaning and maintenance and care. For cardiac, since we are a cardiac unit and he did come in for his heart failure, we would just monitor his heart failure, the hypertension, and also the pleural effusion that he has. Then for the musculoskeletal, since he does have the scleroderma, it does restrict a lot of movement. So we would just monitor the patients for range of movement, ADLs, and strength and independence. And then also his self-esteem, since scleroderma really does disfigure the patient's physical. We would just assess the patient's self-image, the adaptations to the autoimmune disease if it progresses from, instead of being localized to just the skin, to the systematic and the organs. And then we would also just monitor for infections.
So for challenges and solutions, we basically covered a lot of it. So I just want to point out like the important parts. So we're just going to tell our patient that he's going to have to use adequate sun protection when he goes outside, especially with the medications he's on. Some of them cause photosensitivity, so we don't want to put them at any harm with that. So we want to make sure that they use sunscreen, moisturizers, and hand therapies. And yeah. And that's our references. Thank you for listening.
Oh, they all like fell asleep.
Does anybody have any questions for this group?
Nice.
I do.
Oh.
What is aspirin?
What?
What is aspirin?
Say it.
An NSAID? No. Wait, what?
Yeah.
Guys, I'm sorry. I can't.
Antiplatelet.
Antiplatelet. Sorry.
Okay, so is it a blood thinner?
No.
What is it meant to do?
Prevent clotting.
Thank you.
Yeah.
Thank you.
What do we say? Did we say blood thinner?
Does anybody have any other questions for them?
Did you say enzyme? Did you say enzyme?
All right, you're off the hook.
Is it on?
Dan, I am on. Oh, I'm so loud. Okay. So please stay for a few minutes just so that we can all take a picture. Please. Thank you. And I'd like to thank Dan, and I'm sorry, I don't know your name. But thank you anyway, for all your assistance with this process because it was a little painful at a moment, but it got better quick with facilitation from some students. So Delcy, she's not here, but thank you, Delcy. All right. Good job, ladies and gentlemen. You want me to say one more thing? No more things. Oh, good.